So a warm welcome to everybody. Warm welcome to everybody on the screen to this in-public meeting of the CCAM board. Just a couple of things from me before we start. We have a couple of apologies, well, three actually. We have apologies from Joe and apologies from Peter Shield, one of our NEDs, and Janine is also not able to be with us today. It might be worth just mentioning that Simon, the Group Chief Exec, we do have a start date, official start date now, which is Monday the 5th of October, and also that he's going to be spending a few days, one day a week, hopefully, during September, just to get to know people, but not taking over at that point. He's just in the background getting to know everybody. Officially, he takes over the role, but even once he has taken over, as Jen knows, and Stuart in SCAS, they will continue in their role for some time to come. Okay, a couple of things I'd just like to say about governance, if I may, for the benefit of anybody watching, and particularly anybody who watches the recording afterwards. Something which I've got into the habit of saying, it's a bit of a mantra, but quite useful, I think, just to remind people that these board meetings come at the end of a governance cycle, a cycle that starts with the exec meetings, moves through to committees where all the real heavy lifting is done, all the real scrutiny is done, and the assurance work. And then we at the board here, our role is not to repeat that. Our role is not to rehearse all of the good work that's been done in the committee. It's to satisfy ourselves that that has been done, and also to hear from committee chairs if there are things of particular concern. But where things are going well, where assurance has been gained, then we don't seek to repeat that here. Otherwise, we'd end up being here not only all day, but probably for several days. Good. Okay. I think that's probably enough information from me. So can I just check if there are any declarations of interest from anybody this morning? No declaration of interest. Grand. We then move to the minutes of the previous meeting. Peter, anything?
No, Chair, there's I think I haven't had any corrections in terms of factual accuracy, but there was a question from the board last time about the use of pre-hospital video triage, and Richard Quirk, Chief Medical Officer, gave an answer. Since found out that it wasn't quite as accurate as he thought, where he said that we were using that in all bar 2 hospitals. In fact, the position is that we use it as a relevant hospitals in Sussex and Kent. In Surrey, we use it at Frimley, not yet St Peters, East Surrey or Epsom. So the minute's technically accurate because that's what Richard said last time. But what we do is the individual who wrote in with the question will respond to him just correcting that decision.
Perfect. So that was a question from public.
It was, yeah.
Okay, that's great. And that reminds me, I should have said at the outset that obviously it is an in-public meeting, not public meeting, an in-public meeting, which means that we are welcoming your questions from the public. We don't answer them on the day. Take the questions as they come in, and we will answer them as best we can at the next in-public meeting. So if there are any questions from anybody watching today, or indeed anybody who watches the recording subsequently, if you want to put questions to us, please do email them in, and we will do our best to answer them at the next meeting. Okay, so minutes. Can I check anybody else got any comments or corrections, amendments to those minutes? Are we all content to approve those minutes? Thank you very much. And then in relation to the action log, Peter, again, anything?
Yeah, in good shape. There's one open action in relation to the specialist clinician review that's due in December, and the 2 actions on the agenda today, and the others are closed.
Good. Okay, thank you very much. Okay, so the next item we come to then is the chair's report. There's a written report in the pack, which I will take as read. Happy to take any questions from anybody. A couple of things I'll just say there, just to add to it. In relation to the Council of Governors, people will be aware that the health bill is passing through Parliament. Sad soul that I am, I actually spent some time yesterday checking on the government website where that actually is. It's still in the House of Commons. It's at the report stage. Third reading is due, presumably when they come back from recess. Then it moves on to the House of Lords. So it's made good progress through. Hasn't had any major amendments as far as I'm aware. And the 2 big things in that bill for everybody who probably know already is that one relates to the abolition, if that's the right word, of the NHS England, with it being absorbed into the department. But from our point of view, the biggest change probably in relation to Council of Governors is that the appointment of chairs and NEDs, so all of us sitting around the table who are non-exec directors, henceforth our appointments and unappointment, if there is such a word, would be in the hands of the Secretary of State for Health and Social Care, not in the hands of the trusts or indeed the Council of Governors. But we don't have a date for it, but the likelihood is it will receive royal assent later this year. possibly very early next. So that was that. The other information point just to make was we held the integration committee recently. The main item on that was the CAD, and I'm very pleased to say that the joint CAD arrangements are moving ahead quite well. It's much easier here because the CAD here, the new CAD here will be an upgrade, not a replacement, whereas in SCAD it's a much more different situation where they've got 3 separate platforms all being replaced. So it's a much bigger project for them. But I'm pleased to say that some of the initial resistance, worry perhaps rather than resistance, seems to be evaporating in relation to the SCAD side. So that seems to be moving forward particularly well. So I'm happy to answer any questions if there are any before we move on. Yeah,
No one else is going. I think we should mark the fact it's your first formal board and
very much.
Welcome you. So thank you very much. And just interested in your report to see, clearly you've been out and about. I guess the question is around what your first impressions are. And a question on many people's lips is, what do you think the priorities are? So let's get it out into the open and see what you've been thinking so far.
Yeah, sure. Okay. Well, on priorities, I would say I would divide into 2 halves. I would say there's a priority for the kind of medium-term development of the group structure. And then we've got priorities which are related to where each of the individual trusts. And here we're talking about CCAM. So what are CCAM's priorities this particular year? You know, what's Jen got on her mind? What do we have to deliver? So I think we have to separate the 2, and they are quite different. Clearly the priorities today for CCAM are to continue with the good performance, financially to come into balance. He glances at Simon to see an inscrutable looking face. But we'll hear more about finance in due course. So far, I think they're okay. So that's a clear priority. We've got to continue to develop a balanced budget and to deliver the SIP programmes. We've also got to ensure we're delivering on our CAT2 performances and other performances. Extraordinary performance, by the way, on the answers for 999s.
The call answering.
Yeah, the call answering. Yeah, 5-second target within 1 second at the moment, which is quite extraordinary. Really good. So I think that the priorities in terms of where we are this year for this trust are fairly clear and fairly straightforward. Then the priorities for the group and in terms of how we're going to maximise group efficiency are much less clear because we've actually got to work through that. And until Simon arrives, those conversations are kind of slightly, kind of in abeyance. But we do need to work through how we are going to deliver the expected benefits in terms of efficiency and effectiveness and sort of economy of scale that we could achieve by being a group. And we've got to start thinking about how we can do that in everything that we do to ensure that patient experience is benefited by being a group and not disbenefited. Potential that things could go the wrong way. So they would be my priorities.
Thank you.
Is that helpful? Okay. See you back.
Morgan.
Oh, mark that down as my first
You must
mistake.
be thinking about
Mark that down. First mistake. Marjan, sorry. I'm looking straight at you and going,
The nameplate's too far away.
No, I know.
No, thank you for your report. I was interested in hearing more about the future role of the governors, or is the office just going to be eliminated, or are we going to concentrate more around hearing patient voice, and be doing more work around that, because that is one of our priorities.
Right. And the answer is, I can't give you an answer in that I think it's the case that trusts will be expected to migrate, that's the right word, their council of governors into something which is more aligned to patient voice. So it will still exist, whether it's the same people, and exactly what we will be asking them to do, I'm not sure. I think that it is going to be within the gift of the trust. So my assumption, my working assumption at the moment, is that what we will need to do is to come together once it is completely clear because at the moment it is a bill, not an act, and there is the potential for amendment. So it's no point in rushing too far ahead of ourselves. But assuming that it goes through unamended as it's currently written, then my understanding is that all trusts will need to create some kind of patient voice to replace the current Council of Governors. So it will be in our gift to design it. And then having designed it, we will then need to consider the membership. And indeed, some of the current members, some of the Council of Governors who sit on the council may choose not to do so in the future, because obviously they had specific responsibilities around holding NEDs to account, holding committees to account, the appointment of NEDs, the appointment of chairs, the fact that all that will no longer be within their gift. Some of them may decide actually they don't really want to be a part of that body, which is fine, and it may suit others. So I think there's quite a bit of thinking to be done about it, but I think that's the way it will go. And there's certainly a requirement in the Act for something to be put into place to replace it.
Oh, sorry, Colin, if I could just add a comment on that. It was just to say that we certainly completely agree. We certainly do intend to consider how we can evolve what has been the Governor Forum as part of both the patient and the staff voice within our kind of service portfolio. So Janine, Sarah and I are thinking about that with Joe as well, just to try and bring a kind of overarching like coherence to all of our engagement activities and all of our kind of advisory voice that we hear from both staff and patients. So I think something will definitely evolve from the Governor Forum in that regard.
Yes. Okay. Thanks.
Just to sort of welcome that, I think there's a real danger you could lose that voice, and actually that voice is really important. So it's really that's critical. The area I want to sort of pick up is around succession planning and around NEDs. And so, I mean, at the present moment, both trusts effectively have vacancies and also have vacancies in the pipeline. And just in terms of I mean. There's an inherent danger. I chair both people committees, for example, and we are struggling, for example, for NEDs to be on that just because of we are down on numbers more than anything else. So I'm just wondering whether there is any sort of, the search certainly on the SCAS side didn't yield what they were looking for. So there are definitely, there are at least 2 to 3 vacancies coming up, and some the same here. So I'm just wondering where your head's at on that.
Absolutely. One of the things on my mind is that the more cross-fertilisation, if I can put it that way, that we can get from individuals, particularly in the NED camp, across the 2 boards, the better. Harbhajan, you, of course, have the unique position at the moment of sitting both on this board and on the SCAS board, which I think has been a very positive position to be in. And I think that your ability to be able to have a foot in both camps, if I can put it that way, and understand both the benefits and the challenges in both camps has been really, really very useful. So I have been encouraging an extension of that move in SCAS, and you know that we have 2 vacancies in SCAS at the moment. So I'm hopeful, subject to Council of Governors agreement, that we may find similar arrangements are being created to fill those 2 gaps in SCAS. Possibly even this week, actually, the Council of Governors meeting on Friday to consider that proposition. So I'm hopeful that we will be able to do that and get some more double running, which will be helpful. I'm conscious that we've also had 1 resignation here due to other commitments, unfortunately, but that's the way things go. So there will shortly be a vacancy for another board member here. I think the general feeling, talking to Peter and others, is that we can probably carry that vacancy for a bit, because you are in this trust reasonably well populated with non-exec directors, so it's not a critical matter to have 1 vacancy, rather than rush ahead whilst we are considering what the future of the group boards will be. So I think, in short, very conscious of the succession planning issues, very conscious that we need to fill gaps, particularly in SCAS at the moment. If we can do it by finding individuals who are happy to follow your train up and down and have a foot in both camps, then we will do that. Is that sufficient? It's brilliant. Good. Any other questions? Shall we move on? All right. In that case, let's move on. So next item is Audit Committee. And I think, Carl, you're going to give us a brief overview of Audit Committee?
Yes, Chair. I'm going to cover Peter's way. So the papers there, I'll just run through a couple of highlights and happy again to take any questions. I guess the key thing at the beginning was that there was no escalations of any significant internal controls from the other subcommittees. What was noted was around the continued focus on virtual care and the operating and financial plan, all of which I think will get further coverage today as well in the discussion, no doubt. We did cover and it's up for endorsement on the next item, the amendments to the revisions to the risk appetite framework. It is noteworthy, if it doesn't come across here, that the Trust has moved in its maturity significantly in terms of how it both identifies and manages risk, and this is about how does the trust move to the next stage. Some of that will be about understanding how you apply risk appetite, I guess, more globally across the organisation, but equally how do we use that effectively at the board level, and Peter and team doing a lot of sterling work in that area. Probably then worth people noting that we did get some very good internal audit reports in this meeting. They are truly independent in terms of what they look at. We've had a mixture of reports over the past year, but two very positive reports, one on health and safety, one on cyber assurance. And I would like to point out that we reviewed the IT asset management improvement plan, which had a limited assurance when the internal audit was carried out, and that's been really positive in the sense of all actions completed or in train, and therefore greater assurance forward and to the overall trust around our level of management of that. And it's down to Nick and his team in responding to that, but also all individuals have to then comply with that in terms of how we manage assets. And just the last thing was, again, it was a fairly positive meeting overall, which I probably shouldn't say out there, but sometimes quite rare for an audit and risk committee. But single tender waivers, again, reducing in the last 12 months, much greater control over in that space, and clear transparency where a single tender is awarded. So yeah, very positive meeting, but happy to take inputs.
Good. Thanks, Carl. Grand. Any questions to Carl from the audit committee perspective? No?
That's because I'm deputised.
Saving them all up till Peter returns. So in that case, it's over to you, Peter, for the...
Just to follow on from what Carl's said there, Chair, in relation to the risk appetite framework. So it's formally here before the board for its approval, having approved the first version of the framework around this time last year. So what this, as we discussed at the audit committee and before that, the executive management board, this builds on the first 12 months of the framework, using the learnings during that period. We introduced concepts like risk tolerance, risk proximity, and we've adapted the risk appetite boundaries. So we've moved from 4 risk appetite levels from 3. That gives us a bit more flexibility. So I'm personally, really quite encouraged by the way that we've kind of piloted it in the first 12 months. It was being well received by the organisation. Still a way to go, of course. It's just, first year, and speaking to other organisations at this in similar time or longer, they're still, moving the sort of goalposts a little bit just to flex as they learn. So as I said at the audit committee, it's when you boil it down, it's just another way of approaching risk to make sure that we're focused on the right areas, and having the right discussions, particularly at board and board committee level. So, for example, in the next board cycle, using this new framework, we'll be having a focus on those BAF risks, which we'll come to later on today's agenda, that are outside of appetite, so that the committees on behalf of the board can seek assurance that we've got the timely actions to bring those within appetite over the next period, and obviously they'll report back to the board in the usual way. So as I say, the other thing to say is that this framework's also informed a recent BDO risk maturity assessment that's due to report to the audit committee in September. Just yesterday or day before, got started for first draft, and again that's quite positive in its assessment. So it's a reassessment of the one they did 18 months ago, and it's showing good progress in terms of how we're moving that forward. So that's just another external sort of validation of the work that we've been doing. So yeah, formally for the board, so thumbs up. We can move on.
Okay, that's grand. Any questions to Peter on a very comprehensive document? It's interesting, isn't it, moving to agree a risk appetite and to agree a tolerance. In a committee, you can spend hours on those topics, but it's good to see it. One of the things I noticed, just not for discussion now, but just out of interest, that you've got the 4 different categories of a tolerance to risk, from meagre right across to very adverse. And I think I'm right in saying at the moment everything sits in the 2 middle categories. It's either is it open, yes, open or cautious. And I was just thinking that if an organisation is going to really transform itself, then it's probably got to be willing to be open, be more willing to take some risks. And so the eager category, particularly on some of the sort of transformation things, it's going to be an interesting debate, I think, as time goes by, as to whether we, as a group, are willing to to accept and embrace a high level of risk in some areas.
Chair, if I could just
Yeah.
just add, so we did start some of that conversation around, and there's probably a little bit of continued education for us all in how do we use that and understand the difference between where we clearly do want to take risks to improve the organisation overall and the outcomes for patients, but what are the barriers, and then what are the red lines to where we're not? There are certain areas, regulatory, where you're just not, you cannot take a risk in this space. So, so again, my recommendation in the conversation separately with Peter Ruby was that if we revisit some of that as a board, so we understand that we're driving this to support decision making, rather than we're saying, look, isn't it good because we know what our risk appetite is.
Yeah,
it will shift as well.
Absolutely, and and in some senses, I would be encouraging us to be open to take more risk in some areas, but also be open to at least a discussion about being less risk tolerant, more averse in some areas, because some, as you say, there are some mandatory things that we just have to deliver.
Yeah.
And so I'm not sure that we even have the ability to be able to slide slightly to the left on that. We probably have to be extremely averse in some areas. So I think broadly it would be quite a useful discussion.
And you should populate. You should, in the end, you normally see a population across.
It's what you'd expect, and that I'm very interested to see that everything was in the middle. So you exactly as you described, Karen.
Yes, and again, I think just to thank Peter and others for all the hard work that's gone into this, because it has been good to see how we've been developing this over the last couple of years, and it's really useful, I think, in terms of some of the challenges that we've got ahead to use these kinds of frameworks. Just a few points, if I may. Just on the risk appetite thing, I mean, endorse comments made by others. My other point is how interdependent some of these are. So, for example, what often happens is research and innovation often gets scored as fairly open because there's an assumption that, well, this is a good thing, we should be doing it. I think there's also something in there around a word of caution, particularly when patients are subject, which you will notice anything to do with patient safety. We have, understandably and quite rightly, a much lower risk appetite. So something around how we work with some of those nuances around the different conflicting aspects of the specific thing that we're looking at. I think the other thing that struck me going through this is obviously this is always constrained by the limits of our imagination, and there's always then the unknown unknowns, and particularly for a service such as ours, there's, I think, a big piece of work around the resilience planning that we have to do in terms of disaster, etc. So I suppose my question is around the assurance we can get on that in terms of feeding this into these kind of frameworks. And I'm interested to hear from the execs about the challenges of doing that, because quite a lot of our work, isn't it, is being very responsive.
Do you want to spot Jen to
Well, you were looking at me, Karen.
No, that was just. And maybe it's not necessarily a question to answer now, but I think as we're developing these, there is something about, it's not that long since we had the pandemic. And again, these kind of things, then people say, oh, we'll learn all of these lessons. And then, of course, we moved on to the next crisis that comes along. So there's something in here about how we keep the right things on the table.
Yeah.
I think I was going to make a perhaps separate but related point, but I don't think necessarily, I think perhaps that's something for us to take away and consider. But I think what you're asking us to be thoughtful about, Karen, is what is the right level of business continuity, resilience, kind of planning that we should do in order that we are sensibly, looking ahead, being proactive, like planning for risks, whether they be clinical or organisational or cyber or whatever. And we've got some very obvious parts of our service that do that, the resilience function and the specialist operations, but those are not the only ones. So what's the right level of kind of contingency planning, as it were, that is like proportionate to the risk? And then the counterpart to that, I suppose, that I was going to raise is what is, and I think you touched on this as well, what is the right level of proactive, innovative action that we can take to actually make some of these risk appetites a reality? So when we talked about this at exec, we started, but perhaps haven't fully explored the question on page 7 about, are we doing enough quickly enough? And those might be corrective actions to manage a risk that we're cautious about and that's not where it should be, but they might also be proactive, innovative actions to take a risk. You know, I can think of a number of examples where we want to improve the effectiveness of our care within the constraints that we operate within. We're always making choices about the kinds of risk appetite and tolerance we have for different sorts of care for patients in the individual and the collective. So what's our, you know, what innovation can we bring to that, and be thinking, I've had a really good conversation with Joe about the risk that we see and the risk that we don't see, the harm that we see and the harm that we don't see to our broader population. So what's our kind of you know, more proactive, more innovative decision making around that, and the same applies to a number of other areas. So I think both of those areas, like what's the right resilience and continuity planning, and what's the right level of more open, proactive, innovative decision making, are really good ones for us to take forward.
And okay, for the moment, just a general thought to express for people to consider as time goes by. Shall we? I'm not sure what order we're in, so we'll just go around the table. Shall we go to Liz first, and then we'll go?
Thanks. Can I ask Peter, what's the next steps with this and the cascade? Because I'm very aware throughout the organisation, our people are assessing risk every minute of every day when they're out there as well. So how will we ripple this down and through and potentially change our risk appetite out there?
Yeah, so good question. All of our risk leads come together under the sort of purview of the risk assurance group that meets on a bi-monthly basis. So next meeting, in about 3 or 4 weeks' time, Ruby's going to run a session with all of the risk leads across each of our directorates on this new framework, subject to its approval. And then the cascade will be, so Ruby's doing some work with our divisional governance groups at the moment to, you know, ahead of this approved framework, to introduce the concepts. And as I understand it, the engagement with those divisional governance groups has been really positive, because they're asking really curious questions about risk, which itself is really assuring. So yeah, lots of work in her work plan in particular over the next 12 months to make sure that it goes through to the various directorate and divisional governance layers.
Peter, are you asking for the board to approve the risk appetite framework? Is that a formal request?
Yes, please.
Sorry, Colin, before you do that, it's a great framework, but it's actually very CCAM looking downwards, and I'm wondering where we're actually bringing some of the risks which are strategic across the group model piece, and the ownership of that has got to sit around effectively these two tables, and I'm just wondering how we build that in, because there are external risks identified, and I get those external risks, but these sort of sit halfway between that, because actually there are some real risks of us not moving at pace, not actually doing the work in terms of driving efficiencies. They're hidden in some of the finance ones and the people ones, but I'm just wondering whether we bring them out in a different way. It's just a...
Yeah, it's a good point. And at our recent exec development session just last week, we reminded ourselves, remember, in the room downstairs, when the two boards came together last October and we had that risk mapping exercise. So I think it'll be helpful to kind of effectively kind of redo that in today's context, see what those strategic risks across the group are. On the framework itself, though, so it is a CCAM risk appetite framework. SCAS have some things slightly different. Ruby and her counterpart are hopefully by the end of this financial year trying to ensure that they align, so we're using the same language and the same approaches across both us and SCAS.
It's a good point, isn't it? I mean, clearly, our work here today is with CCAM focus. So this is the proposition is, are we happy to accept this as a CCAM board for the time being? But the point you raise is a very valid one. It might be something that the integration committee might want to consider. Because that committee has been very much focusing on the CAD initiative, but that seems to be moving on quite nicely. So this might be something it could evolve into. So perhaps we can put offline, Peter, and think about that as something that the integration committee.
Yeah, so just to be clear, in case it hasn't come across, that the audit risk committee are recommending that it is adopted.
Yes,
by
thank you.
Has had that debate and scrutiny.
Yes, no, thanks, Carl. Any other questions then before we just go to the approval or otherwise?
I don't think it's changed a lot since last year, this, has it, at all? So there might be more risk categories to help with the resilience. There might be other changes. Certainly, the working in partnerships dialed up a lot. I just wondered has it changed very much, or are we going to revisit it before next year?
So it's changed. It's evolved. So it's not massive changes. There are some, some specific changes, like for example, in terms of the levels of risk that we're now applying for the framework. But yes, it's going to be continually, and this was the learning from the national webinar we had that we attended recently, where people were saying, introducing these types of frameworks, is that the learning from that is that you need to keep it dynamic and change as you learn and as you want to apply it to your local context. So certainly isn't going to be, a static framework. We'll evolve it as we go for sure, as we have done in the last 12 months.
Right. So we will revisit it at some point.
Yeah.
Thank you. Thanks, Paul. Any other questions? Are we content then to take the recommendation from Audit Committee and to approve this as the CCAM board? We are all content? Very good. Thank you very much. In that case, we move on to Shadow Board. I think it's over to you, Karen.
Thank you, Colin. So for your benefit, the Shadow Board was an initiative that was started nearly a couple of years ago now, I think, and it's evolving in terms of its function. We were very clear at the beginning, I think, that it wasn't a kind of quasi-second shadow board as a development opportunity for people going directly into different roles. This was more about getting different voices into the board, and there's been a whole development programme behind it. So I'd like to start, if I may, just briefly by introducing some of the shadow board who are here today. So on screen we've got Hannah Sewell. She might switch her camera on and give us a wave. And then behind us we've got Philip and Mark, and Aid in the back, and Liz and Susan are two of the individuals that have been very closely involved in supporting the group and getting it off the ground, which is fabulous. Hello, Hannah, welcome. And whilst I'm here, can I also welcome Sarah EOC, who's also come to watch the board meeting today. So thank you for that.
Yeah.
And I think it's worth saying at this point, just another acknowledgement, is I know we had some good news at the Shadow Board meeting on Monday that apparently because of the interest in submitting for national awards on the basis of some of the achievements of this board, we've been shortlisted for 2 quite high profile awards. So we're very excited about that and hopefully have some more news on that in November. In terms of some of the detail, I'll talk you briefly through some of the main things that we did in this latest board meeting. And the format we have is we usually look at the CEO report and what kind of questions that provoked. And there was some good discussions and for feedback for you, Jen. Again, I think what's interested is in this process is the symbiosis between what the Shadow Board are raising up and also then how that fits with the board agenda. And for me, that's very much an acid test about whether there is synchronicity between the two. And I think when there's good overlap, for me, that's a good indicator. There will be some differences, but I'm beginning to see more of that coming together, which I think is reassuring from both ends. So the things we talked about in your report, Jen, were around questions around the hear and treat trajectories, about how CCAM's performance metrics compared with other ambulance services. And there was also quite a lot of interest in the independent culture review, which we'll say a bit more when we come on to, because Sarah also attended that meeting. You might want to say something about some of the things that we talked about in that. So one of the main items was the violence and aggression update. So this was a piece of work where the Shadow Board actually prepared a paper which was brought to one of our board sessions with some proposals and thoughts and raising some concerns. And there's been a significant piece of work that's been taken up by the executive and others over the last 8 months or so, which is beginning to yield some really interesting results. So we had some time in this session with Dave Monk, who's been doing a lot of that work in terms of taking forward some of the actions. And one of the things that I think was interesting that came out from that, Dave said one of the questions he'd been asked by some of the other managers of, well, how did it feel when the Shadow Board raised issues about your department? Did that feel a bit threatening or intimidating. And actually, he said he felt it had been a really good working relationship. And from his perspective, it had enabled bridges to be built and for perhaps some things to be done that couldn't have been done through some of the more formal network. So I think that's another good takeaway from how we're starting to work a bit differently and really getting the staff voice involved in some of these issues. I won't say much more on the outcome of that because that's the next paper and you have a document on that. The ask from the Shadow Board was that a further update would be brought back in another 6 months' time because there's still some pieces of work ongoing from that. And we're looking forward to cooperating with that. And the other request was around the continued focus on psychological safety and learning culture, again, which came out from that. We had, you'll be pleased to know, quite an extensive discussion on virtual care. That's very much a hot topic. And again, I'm not going to spend too long on that because I think many of the issues that they raised have been reflected in the board paper later today, which have captured the main themes that we discussed there. And again, there's an appetite from the Shadow Board to be involved in this and to continue to contribute to the discussion and to influence that in some way. Sarah then came along and we discussed again another paper that's on today's board meeting, the Culture Review. There were some really good questions, I think, around that. And Sarah, I don't know whether I can invite you briefly through the chair just to say a few words about that experience and what came up for you in that.
No, certainly. It was actually a really, really helpful discussion, really insightful questions, thinking about how the findings, I think, from the Culture Review, we'll talk a little bit later about how we're going to use the leadership framework as the sort of vehicle for resetting, I would say, leadership standards and behaviours. And I think some of that discussion was about how we as a sort of leadership team will set those standards and encourage those standards and how we assure ourselves that we are progressing in the right direction. So I think that some of those questions were really helpful, and we certainly discussed as well about whether we should look at our leaders signing up to some sort of leadership pledge compact. And that's certainly something that I've taken away from that discussion to say, how will we do that? And we've got a session next week actually with the wider leadership team where I'm going to ask precisely that question about how are we all going to show our commitment to implementing the leadership framework. So that was really valuable. And I think some of the other feedback around the cultural sort of hotspots, I would call them. So there are pockets of the organisations that there are inconsistent leadership behaviours, and how are we as an executive team focusing on those particular areas. And some of that discussion around how we ask the curious questions as executives, making sure that we are focused on those pockets where we know there are issues, and if we're putting additional interventions into those areas, which we are. So I think really, really helpful and very good questions, actually. Yeah.
Yes, I know.
So it gave me a good run for my money.
Of course, we'll come back to culture as a separate standing item on the agenda later on towards the end.
And then the final thing is we usually have feedback. All members of the Shadow Board get an opportunity while they've been doing the development programme to go and sit in on some of our subcommittees. And then those that have done so feedback to the rest about what they've learned. And this time it was interesting. So one fed back from the Audit Committee, and I was interested, Carl, to hear that one of the recommendations from that was around cascading more information on cybersecurity and the interest in the BDO audit process as well. And again, one of the asks was that actually they thought that was a good idea and they would like to be more involved in some of those training sessions. So that was, again, I think some overlap that was a good, and fraud was another one that they were interested in finding out more. And there was curiosity around the BDO audit process. And again, I think we take for granted that everyone knows what these things are. So they were quite keen to find out more about that. So we're going to look to see whether we can invite some people along to talk a little bit more about that. So that's understood. And I think there was a general review, as we always do at the end, about how people think the shadow board is going. And it was positive, both in terms of the contribution they were feeling they were able to make and feeling heard by our board, and also for their own personal development. I think I've covered most items. I'm sure they'll tell me if I'm wrong, but I can see some nods around the table. So happy to take any questions if there are any.
Look, let's see if there are any questions specifically on the shadow board, and then we'll come. I think, Jackie, you're going to talk about violence and aggression, but we'll leave violence and aggression for the moment. Any specific questions to Karen on shadow board? Oh, right, good. In that case, let's move to that specific paper. A lot of detail in that on violence and aggression, and I think Jackie, you're planning to go on this.
Yes, I am.
Over to you.
Thank you. So the paper in the pack has been to shadow board following the very helpful session that we had at this board a few months ago, and it's also been to the people committee a couple of weeks ago for scrutiny and discussion there, where it was presented by Dave Monk. I'll take the paper as read. I won't go through it in great detail. I think the things perhaps to highlight in response to the very sensible recommendations from the shadow board, we're now seeing that we are having improvements in the number of incidents that are being reported. So they've gone down significantly since last year, and we haven't seen some of the spikes that we might have expected to have seen with the hot weather recently. From the perspective of the NHS violence reduction standards, that's something which the team has been working on for a number of years, and in a very, very good position, I think I'd suggest at this stage, with 95% compliance with that, and the outstanding areas are relating to some procedural aspects which are very much entrenched sort of in the IG space. More specifically, in response to the recommendations, there is considerable work being undertaken to improve the uptake of body-worn video camera. Now, we know from evaluation that the wearing of body-worn video doesn't necessarily reduce the likelihood of you being assaulted in the first place, but it does significantly improve the likelihood of successful conviction in the case of assault, and also has a very important effect to make the wearer feel more safer and secure. So there is some practical work to make sure that those items are available to staff. Work more collaborative and detailed work amongst different parts of the organisation and the police in relation to history marking, and making sure that frequent callers and those who might be more likely to assault staff as a result of mental or physical health problems are identified, so staff can be best prepared in those areas. I'm pleased that a recent internal audit concluded substantial assurance on that front as well. There's a bit more detail in the paper. I'm very happy to field any questions that I'm able to today. I think overall a positive step forward, and I would echo the comments that Karen's made there in terms of how useful the process has been of having something looked at by the shadow board and the opportunity to respond with and alongside the people that are experiencing the issue and make the improvements. And we'll be very happy to bring a further update back to the shadow board in 6 months' time as you request.
Good, thank you. Harper is keen to come in. Subo, get the name right.
Well done.
Right, right, Subo.
Thank you, Chair. Lee or Harper first?
I mean, we had a fairly detailed discussion about this paper at People Committee, and certainly everybody at the People Committee really welcomed the recommendations coming, and it really did sort of show the strength and the importance of something like the shadow board, because it allowed a different perspective to come in, and it also meant that it gave you a different perspective around assurance, because quite often sometimes you can almost get quite a rosy picture, and actually there were a couple of areas in here that actually we did have a little bit more of a conversation with Dave in terms of what's being done, but it also highlighted particular areas for us to be thinking about and focusing in on. So for example, Brighton was mentioned, and actually there is further work to be done on that. So on the back of that, one of the things the People Committee have asked is an update report in terms of the recommendations that were actually put into place. So.
Thanks, Harper. So to Super next.
Thanks, Chair. Thanks very much for the update, Jackie. It's really helpful, and it's really good to know we're making some progress. And I was going to ask what percentage, so 95% is good to know. 2 questions, please. First, your point 3.5.1 you talk about tolerance and zero tolerance policy. So this is a concept that is talked about widely in the NHS, and lots of trusts, including the 2i chair, we've taken a particular position around zero tolerance. You mentioned dementia, and there are some conditions perhaps where there might be some movement, but I think an important concept here is about when you refuse treatment. And obviously lots of healthcare professionals, we're trained to be compassionate and provide, but I think there has to be a standard to support our staff. There comes a point you refuse treatment because they are being violent. So I think it would be good to see that. If the policy is being revised, it'd be good to get your update on that. The other thing in here that I noticed previously when we've talked about the framework, we've talked about de-escalation training. I don't know where we're up to. Is that still being rolled out? If it is, what level of compliance have we achieved on that, or completion have we achieved on that? That would be good to know. Thanks.
Sure. So if I take the first question first, I'll take them in order. From a national expertise perspective, the consistent guidance is not to attempt to work with zero tolerance, because there are groups of patients for whom they don't have the capacity to be making a decision about what they're doing. So we find it quite helpful to think in terms of sometimes the types of influencing factors which the police would prosecute, kind of taken into consideration. So you can choose, for example, to become intoxicated, but you cannot necessarily choose to become hypoglycemic and lash out, in terms of a couple of examples there. There is some national work looking at the practicalities of when ambulance trust clinicians might stop providing care in the context of violence and aggression. So that's a piece of work that is happening at a national level, and that will inform the policy positions that we subsequently seek to attend to losing the ability to speak, apologies. In terms of the timeline, I think we're probably still about 6 months away from that coming to fruition. So I don't think that's something that's going to happen in the next sort of couple of months. In terms of the compliance, we've got a good compliance level. I don't know what the figure is off the top of my head, but I can get that for you and send it over. We are coming toward the end of a cycle of delivering conflict resolution training. So you're right, it's much more about de-escalating and how to avoid if a strike does land on you, it's landing on you in a way that it's less likely to harm you, for example. So that's been a 3-year cycle, and we'll be continuing to provide update training to all the staff groups concerned as a rolling programme as part of the key skills and sort of statutory mandatory approach. What we don't provide is things like restraint training in this organisation. So it's very much about de-escalating a situation, seeing something coming and taking steps to remove yourself and control sort of patients in a way which reduces the likelihood. I don't mean literally control patients, but kind of think about how you lean over people and that kind of.
Yeah, I think that would be really helpful to get that figure. Perhaps we can have that as an action chart. That's all right.
So if it's helpful, in the People Committee report, I don't know what percentage this is, but it says almost 3,600 staff have received the training, and there's a half-day refresher training starting from April next year. That sounds to me like a high percentage of our.
It is a good percentage,
okay.
and I can provide the exact number.
That'd be great. Thank you, Jackie.
I'm just going to make a point on the history, Malkin. Historically at CCAM, we've been reluctant to use police information about the people that they're concerned about, because we're worried about information governance and information sharing. And I just wanted to say, as the Court Guardian representing the board and information governance, I support the use of police information to put on the CAD, and I would like to think that the board would also support that in terms of progressing that action onwards, because I think it's really important that if the police give us information, that we do actually use it and put it on there. We shouldn't see information governance as a blocker to protecting our staff from harm when the police notify us. So I think I can safely say the board is committed to that approach.
Absolutely.
And just pause, because it's a very important issue, just pause to make sure there's no adverse views on that point. Taking police, good. Okay, I assume, Richard, that support is continued. Yes.
Can I just say, because I attended the People Committee, what I found really interesting in this report was Dave working in partnership out there, and it was really small changes that made the biggest difference, such as where are the body cams stored, accessibility, are there enough clips to put them on the uniforms, etc. And I think that minutiae and detail and talking to our OUMs out there and how to make it practically work made sense. So I think there's some lessons from other ways of working that if we were, the feedback from the shadow board working alongside our teams gave the greatest impact and the change to improve how we work going forward.
I think it was in that paper, read so much, I think it was in that paper that was written for the female uniform.
Yes.
And the suitability of female uniforms.
They're on your waist.
Yeah, exactly. They're really interesting issues. Any other questions or comments around? But my reflection on it was, I think, a number of things. First of all, I would just say, I know that you do, but a lot of this is directed at frontline staff, but we've also got to be aware of the aggression, particularly which call handlers face. And having spent quite a lot of time in recent years in contact centres with staff, and indeed only last week in one of our contact centres, people do get a huge amount of aggression, and it's not physical violence, but mentally. It can do a lot of damage to call handlers' well-being when they're faced with repeated aggressive behaviour. I thought the zero tolerance bit as well, I thought that was really interesting. As a layperson reading it, it made me suddenly realise that actually, of course, you can't have zero tolerance. But then, of course, the obvious next question is, how do you define where do you allow some tolerance and where don't you? So I think your point, Stephen, and your answer there was actually really, really helpful. I thought the history markers thing was very interesting as well. And we've got pilots, haven't we, going on in Surrey, Sussex somewhere. There's some more pilots on history markers, so perhaps we can hear more about that as time goes by, because again, as a layperson, it struck me as really rather strange that we would have situations where markers theoretically exist, but actually we're not using them. And the repeat markers, particularly where you've got repeat offenders, people need to be warned about that before they walk into somebody's home. Forewarned can be hugely beneficial. So I thought that was really important. And as I say, from a layperson, I was quite surprised that we hadn't historically done as much as could be done because the information is available, but not actually being given. So the more we give that, the better. But great piece of work. And as you say, it really just underlines the value of the shadow board, doesn't it? And the connection. I mean, the big issue for boards is always how do you get the connection from a board level to operational level, which can be a long way away in terms of both physical distance and reporting lines and communications and so on. So it's really good.
Just on the back of the zero tolerance conversation, it's an interesting one because actually there's a generic message which we want to get out there, which is actually we want to keep our staff safe. And I get the piece around generic, and I'm most probably partially responsible for this because I brought it into a trust about 30 years ago where I worked, because actually what we wanted to do is give assurance to our staff. The reality is you will look at the nuance of the situation in terms of, and that's where that whole piece about recognising that in some instances, you will need to do a risk assessment and actually not necessarily say, right, sorry, we're not going to treat you. So I think part of this is about actually giving comfort to our teams out there to say, we will be supporting you. And so it's about how you get that balance right in terms of the language that we put out on our posters, on the side of our vehicles, etc., about how we expect people to behave towards our staff. I think that's quite important. And maybe the language of zero tolerance isn't perfect, but there is something about actually there's a line that actually we wouldn't allow people to cross.
It's nuanced, isn't it? Because there is a zero tolerance to certain types of behaviour, and there's a slightly less than zero tolerance for other sorts of behaviour, which is perhaps not deliberate or is occasioned because of clinical issues. But even where behaviour is occasioned by clinical issues, we've still got the role of keeping up our food safe. So it's a much more complicated issue, and it does connect, I think, with the cultural paper that we're going to talk about much later on, because there are issues around culturally. How do you actually follow up with prosecutions, and how are you seen to support staff after an event if an event has taken place? Okay, all content with that. We can move on from that. In that case, Jen, it's over to you.
Thanks very much, Colin. So the Chief Exec's report is here for everyone to read. I won't go through it in detail. Just to give a brief summary, I think we're very conscious of the context that we operate within, and that's been quite challenging, in particular in the last 2-3 months with the hot weather, and that challenge has applied across the NHS and across our systems. So we've really seen the impact of that hot weather on our patients and our demand. So that's brought both operational clinical challenges, but also some learning for how we develop our resilience. And then there's the other operating context for us of change, as we change how we move forward with our collaborative working, primarily with the group, but also collaborating with our system partners, and how we build those relationships in the 3 counties that we currently serve. So I'm very conscious of those operating contexts for us of maintaining and improving the quality and safety of our services and the sustainability and the experience of our people while we deal with a challenging operating context and an environment of change. So I think that's really what my report and we as an executive are focused on. And we have to strike that balance between the quality and safety of services, responsiveness, and those very important clinical outcomes that are critical to what we do. I'm pleased to see the cardiac arrest outcome still remaining, a very positive story for us as an organisation. We also need to be sustainable and deliver the productivity, efficiency, build on the potential of digital to make us more financially effective and sustainable, and change the way that we do things through programmes such as the virtual care development, so that we can be fit for the future, as it were. And finally, I think we need to do that in a way that engages and takes our people with us as we change our structures and our workforce makeup for the future. And I think a lot of my report does focus on the enormous amount of activity that we do to try and connect with our workforce, maybe thinking about how that's going to evolve in the future with the changes we've touched on with governors, but also with the broader organisation of the group and the system, as I have mentioned. So I think for me, it's very much about building a shared culture as we move forward, and a shared leadership way of working, and those leadership behaviours that set the standard, set that positive expectation. I think, just referring back to the conversation about zero tolerance, the way I'd like us to lead is by framing positively what we expect. What does good look like, really, for us as leaders? That we're hungry for improvement, that we set high standards of behaviour, that we always put patients at the heart of everything that we do, but that we think beyond individual to system and population, and that we are respectful, courteous and kind to our colleagues. So those kind of positive ways of leading are really, really important to us, and continue to be what we want to build within CCAM on our ongoing journey, and also come together with colleagues from SCAS to make that a joint endeavour. And we've had a number of really positive interactions with SCAS colleagues at all levels, from operational through to executive, over the last few weeks. So I think we're in a good place. We've marked a 20-year anniversary of the creation of CCAM, and we move forward to further developments of CCAM on an even bigger scale. So it's always a journey. There's still lots and lots of work to do, and I absolutely acknowledge that. But I think that we have continued to hold onto our board assurance framework priorities that represent improving responsiveness, clinical outcomes, changing our models and pathways of care, and being more sustainable, and paying attention to our structures and workforce and culture. So I think we've got the right priorities, and we're making progress on them both individually and as part of the group. So I think we're in a good place. Let's not lose focus on what we need to do through the second half of the year, because it will continue to be challenging, and there'll continue to be change, and that requires us to lead from the front and with positive intent.
Thank you, Jen. So any questions to our Chief Executive?
Thank you, Chair. Thanks for your report, Jen. Really interesting. Just one observation and a couple of questions. First of all, well done to everyone, the organisation, on cardiac survival rates. It's really good to maintain that, I think, in some very challenging times, I think is excellent. So well done on that. You refer in point 48, you talk about the continued growth of Good SAM, and Liz will know we talk about this quite often at Quality Committee. I'd like to have some figures around that. When you say the growth of Good SAM, from what to what, and do we have a target? It'd also be good to be reminded those who are not on quality committee, what was the target on cardiac survival rate? And, you know, how do you think we are doing getting there over the life cycle of our strategy? And then just an observation on the warm weather. And it's frustrating for everyone in the NHS, not just us, but everyone. There is a public health need here, and I don't know about how we can influence some of that agenda nationally around public health, because people do need to be educated around dehydration, sunstroke, etc., etc. We're only going to get more of this, which means, you know, we're going to continue to have this round the year demand. So who do we need to work with? Who do we need to influence around public health, around, you know, how to cope in warmer climates? It doesn't help when water companies tell you to drink less water because we've got a water shortage. For example, I could not believe it when I heard that. I was like, oh my God. So, you know, there is something here about maybe escalating this up. This is not something we can just carry on our own. That's a great burden for us to be doing a public health campaign on, you know, educating people about how to look after themselves in warm weather. So I put that out there, whether there is something that needs to be escalated nationally on that. So those are my two questions.
Right, hang on a minute, let me try and recall. So on the question of public health, so I totally agree with you, Sue. I think there is, public health is so difficult, and there's so much that you could do, and it is quite difficult to achieve. You know, if public health was simple, we'd have solved it by now. Joe and I met actually with one of our MPs from Worthing, who is a public health consultant, actually. And we had, you know, touched on some of these points. So there is, I think, something we can do. There's probably two approaches that we are sort of progressing. One is the public health messaging about looking after yourself, empowering patients to know how best to keep themselves healthy in hot weather and cold, in fact. And we are progressing to that through the development of our kind of resilience plans. We're now very much here and jointly with Scouts thinking of not just thinking of a winter plan, but thinking of a resilience plan that will apply, like Lucas, our resilience director, says, you know, if it's hot, if it's cold, they're similar challenges because people experience health challenges as a result. So we are very much developing a sort of joint communication plan with SCAS around kind of resilience for the public, and also we will be bringing that up with national partners, with system partners, and with national partners in all of those forums. So you'll hear more about that in the October board and in the run up to it through committees, because we'll be bringing that plan back through. The other approach we're taking is through AACE, where we're trying to promote better public awareness of the role of the ambulance service. So focusing on kind of, you know, our part of the puzzle, as it were, because we are not, like, per se, our kind of prime focus, I suppose, is not a public health organisation. But we're trying to educate and inform the public, because we notice that, of course, there is a bit of a preconception that the ambulance service is paramedics in a truck that take you to hospital. And clearly we do. A, we do a lot more than that. And B, we'd like people to be as intentional and mindful of, you know, how they choose to use services as we can get them to be. So we're doing something through AACE on that front as well. And then finally, I suppose from an engagement point of view, on a kind of broader level, we are an anchor institution as an NHS institution. And I think just some of the early work that we're doing around role modelling, I suppose, as an institution, what we can do to be green, to be sustainable, to be fostering health and well-being in our workforce. So we're currently at, like, kind of the early stages of a piece of work which promotes physical health and well-being within our workforce, and thinks about, like, how can we make those small changes from chocolate vending machines to healthy ready meal vending machines. How can we offer our staff, you know, more coordinated offer in terms of physical health, access to you know, gym facilities or classes, or, you know, connecting people to do walking groups and stuff. There's a lot of local activities, but I think that role as a kind of advocate for public health staff is really, really important. So all of those kind of three things are, I think, our primary approach around what you've described there, Sibo, which I agree with. I mean, I'm not sure I can influence the water companies telling you to drink less, but we'll see what we can do. To your question about Good Sam and cardiac arrest survival. So our BAF target is to improve cardiac arrest survival by 1% and to reduce variation, particularly in the bottom 20 decile geographies. We are due, I think, did we agree, Jackie, in November to bring this back through in terms of an update on all of this work in more detail? So that will make its way through, I think I'm probably right in saying maybe the December board cycle. And we're planning to bring together the cardiac arrest survival and the community resilience strategy and Good Sam implementation. So we do have a kind of forward plan for that. And if it's acceptable, Sibo will ask to capture that for our kind of forward plan so that we can inform you.
So Jen is due at UPSC in September, so it's already scheduled in on the cycle of business.
Yes, okay, all right. We'll probably just check what we're bringing in September, because I think we're then planning to do something around the AACE chain of survival cardiac arrest strategy in November as well.
Yeah, so AACE are working on a sector level strategy for cardiac arrest, and they're moving some very, very ambitious stretch targets for survival. So assuming that has been approved by that stage, we'll be able to focus in a little bit more on that. We've had advance and been involved in the development of that.
We're quite keen to be coherent for board colleagues, so to talk about cardiac arrest and community resilience and Good Sam. Obviously they're not the same thing, but they are related in a coordinated fashion. So I think, Pete, we can just check the dates offline, but I'm keen to bring something on the progress on community resilience and Good Sam in alignment with that plan.
Okay. So presumably the figures will be in there.
Yes, they will be. Yes.
Good. Thank you. Thanks, Sibo. Any other questions? Yes.
Jen, thank you very much. I was just going to ask about strategic partnership and commissioning. Looking at the growth of our activity, unexpected over budget, it's a significant volume of activity, both to our call handlers and to our call outs. Have you fed that back to our commissioner? Are we going to get any more funding from that, or are we just absorbing all of that within? Because it's double figures increasing growth of activity currently, isn't it?
Yeah, I mean, we did plan for an increase in activity in this year, but not nearly as large a one as has been experienced in the first quarter of the year. And as has been the pattern in previous years, we had expected a greater increase in activity over the winter than the summer. So I think what's more unusual than usual, as it were, is the increase in the earlier part of the year. That is exactly the same, basically, for all ambulance services and NHS providers. I'm going to say exactly, it's not exactly the same, but it's a common experience for all providers. Both local commissioners and NHSE are really well aware of that, and I'm looking at the national figures now, and the increases in demand are evident everywhere. We have had a very constructive conversation that Simon led with commissioners about recognising the impact of demand on our delivery of our plan, and we are going to cover that briefly in the item under sustainability. So I think perhaps if we might defer a sort of more detailed discussion to that point, that'd be helpful.
Thank you very much. Cool. Yeah. So we're currently 16% above. Demand's gone through the roof. I just wondered how our teams are coping, and if we're doing enough to support them. Well, as much as we can to support them.
Yeah, we are doing that, and I mean we had quite a comprehensive campaign of kind of colleague support during the hot weather, because obviously we recognise that also the hot weather exacerbates working conditions as well as patient demand. I think we do actually have a very robust staff wellbeing and support framework here at CCAM. So I am assured that through the kind of leadership structures and through the services and the offer, we have done as much as we can to support colleagues. We've had to try and, well, actually it's quite fortunate, because what we'd like to do is to put more resources into upstream care, to virtual care, because that's actually really, really helpful in the context of the increased demand. And of course, colleagues can then benefit from working in a air-conditioned environment in the heat wave, in a excellent access to water and various facilities. So perhaps there's an opportunity for us to kind of kill two birds with one stone, as it were, and promote the the benefits of that kind of working. But yeah, I think it's a really good question, Paul, but we have focused very much on colleague support as well as meeting patient demands.
It's continuing, isn't it? It's not that we're doing enough and sure we're doing anything else, that's all.
Yeah, I think, and we have done additional things during the heat wave. I mean, obviously the heat is, although still warm, is not perhaps excessive in quite the same way at the moment. So we hope things will continue to be a little bit calmer from a heat perspective, but I believe there is more hot weather anticipated. So, yeah.
Thank you, Paul. Carmen, and then we'll come to Carmen. Okay, Carmen, again.
Yes, thank you. So thank you for your report, Jen. I mean, aside from juggling all the pressures that you've had, it's impressive to see how you've been out and about and so visible with everything. And on top of that, a 55-mile charity bike ride.
Physical health and well-being, championing it, speak from the front. I mean, I wasn't at the front of the bike ride, I was near the back.
So, and on that theme, I noticed you'd also been to a couple of the leadership and AAs things where the theme of the events have been health and well-being on workforce. And I just wondered if you'd picked up anything that coming over the horizon that might be useful that we're not already tackling, and just it's interesting to get some feedback from some of the themes that are talked about there.
Yeah, I mean, I think the main one was the National Ambulance Wellbeing Forum, but that was more about us. We took a kind of discussion point around some of the early work that we're doing about promoting physical health within the service and being a kind of role model in that sense. And actually, it was really heartening to hear that a number of other ambulance services are also thinking about that, but in a bit of a disjointed way. So what we took away is it would be really helpful to have a coordinated approach across the sector because the challenges are similar. Yeah. Actually, personally, I think the challenges are also similar. I've got obviously quite a varied background in the NHS, and the challenges are quite similar in all NHS organisations about how do we support people's health and well-being when they're working in, you know, sometimes challenging clinical environments, in shift work and other pressures. And it's not an easy equation, but I feel really strongly that there's something about us being role modelling that public health being the change that we want to be. So how do we help people to do that through both like push and pull factors? So we had a really good discussion about that, and we're going to explore it further. And I think there might be something for us to take forward into the Ambulance Leadership Forum and those kind of mechanisms through AACE moving forward. So yeah, that would be good. Thanks.
Thanks, Karen. Carl.
Thanks, yeah. Although based on that conversation, I might have to rethink my sausage roll at lunch. I just wanted to come back to leadership. I mean, it's hard to argue against you thinking of, you know, positive leadership and getting it out there. But however much we desire that, that's not always the case. So if you've got kind of any practical examples of what you're looking to do as an organisation to kind of either embed or recognise those desired behaviours, you know, it is that. What's going to make a difference in me to I guess, step up to some of the stuff you're looking for?
Absolutely. And I think the next stage of implementation of the leadership framework is to define those behaviours and professional standards that we expect more clearly, and to take and be seen to take like kind of positive action to promote those standards, but also action where those standards are fallen short of, that is clear, because we have to both live those values and behaviours, but also be clear and call it out and take action where that's not so. And that's part of the message, I think, that the culture review told us, really. So we just discussed in exec, and Jackie or Sarah might want to just add to this answer. We've got a kind of programme of events over the next 2 months, I think it is roughly, of working with our exec senior leadership and kind of broader leader cohort to define the professional standards, to define the behaviours, to ask people to gain skills in performing them, but also make a commitment to demonstrating those behaviours in order, I think, to make it actionable. To your point, Carl, I think that's really what we're saying. It's all very well to have a theoretical framework, that's very valuable, but you then have to put it into actual action of what it is that you're going to do, what is the standard that you're going to adhere to, and that you're going to hold others to account for adhering to. So that is the plan of the next 2 months. I don't know, Sarah, I think
yeah,
waving.
Probably add to that. So I think series of events that we've got planned with the wider leadership team, progressing to a leadership sort of conference planned for October, is very much focused on leadership behaviours and embedding those. Part of that plan, I think in our leadership sort of framework, we've got like a 70-20-10 sort of differentiation in terms of learning, so experiential learning. Then you've got like what people do in terms of coaching, mentoring, support, and using that around their, promoting different and positive leadership behaviours. The other thing that is really important to this is staff feedback. So 360, using the 360 sort of appraisal process to then embed that into a growing culture of feedback on leadership behaviours, leadership approaches, and making sure we also triangulate information through things like staff survey. So, what differentiates different leadership team? What does good look like? And promoting some of that, because we know that there are really good examples in our organisation around leadership and leadership behaviours. Equally, we know there are challenges elsewhere. So I think it's really important for us as a sort of executive team and a board to look at the data that supports that, to say, where have we got increased patient complaints? Where have we got increased freedom to speak up? How does that link into the staff survey feedback, the narrative, the free text? What are people saying about their local leadership teams? Because I think having embedded the divisional model, it's really important that leadership accountability at local level is a key driver around strategic culture change. So I think there are a number of different ways that we will approach this, but I think having the opportunity really over the next sort of 6 to 8 weeks to promote the leadership framework as the vehicle for that sort of reset and culture change is going to be really important, and then embedding that sort of data and evidence and being curious, I think, as an executive team about where we hear that there is inconsistency in leadership behaviour, that we respond to that, and we respond to that quickly.
No, that's really helpful to hear. I think, the reality sometimes it's a little bit easier to recognise where it's going well than it is to challenge where it isn't. And so I'm hearing you've got both of those things within it. And with that accountability, because accountability means you're empowering people, right? And therefore that challenge has to be able to permeate its way through the organisation.
I think, just to say one more thing, I think it's really important to recognise that good leadership and good leadership behaviours and high standards are not aimed, in fact, to make everyone happy all of the time, no. Nor indeed will that be the outcome. And so good leadership operates in the kind of challenging context that we operate in and makes the right or the best decisions in the context of the time and the knowledge and the best information available. And that's one of the qualities that we look at as a provider capability assessment, as an insightful board. So I think that principle needs to apply. We need to give people the confidence to demonstrate the right behaviours throughout our leadership tiers, recognising that clearly, a positive working environment, good conditions, a good experience at work is important. But that doesn't supersede doing the right thing for patients and demonstrating behaviours that can sometimes, need us to make more challenging decisions. So I think that principle, that shift perhaps, is important. And in how we look at the data, that's important also.
Just before you do, it's interesting, isn't it, that yet again, for the second time, we've quite rightly, we've drifted into the cultural piece, which we're going to be talking about again at the end. And it's just worth referencing that, so much of these things we talk about are interconnected. You can't put them into a single pigeonhole. Sorry, Jane.
There's just a couple of things to add there. So Sarah mentioned the leadership framework is based on the 70-20-10 model, and if you look at the 20 and the 10 elements of it, the coaching, the what you can learn from each other, and the more taught learning, that stuff's quite straightforward. So we're spending a bit of time looking at actually within the 70% start of it. part of it, the things that you learn from your work in practice, from your leadership in practice, and providing opportunities and tools for people to use. So things like reflective practice and action learning sets, for example, are something which are very familiar in some areas, in particular clinical practice. Clinicians will always spend time in reflection on their clinical work, and what we're trying to do is reset the way that we work more broadly, so that actually we're also making sure that we have the tools and the familiarity with how we reflect on a difficult conversation which didn't go particularly well with a member of staff, as well as perhaps a clinical interaction which didn't have the outcome that we want to try and use some of the tools which are already out there and familiar in other zones and bring that into our leadership work and practice as well.
Okay, thank you. Good, thank you very much. Couple of comments from me, if I may, and then we'll move on. You make reference to where the trust is in terms of the NOF and also the regional office gradings.
Yes.
And I think we should just reference that in the minutes, that we are in a fortunate position at the moment in terms of the regional gradings, that we are in the highest tier, which also means the lowest tier of worry. It's the reverse numbering. You kind of think that 1 is good and 3 is bad. Well, it's the other way around. So we're on 3, which is the best place to be. But I think that it will be worthwhile, perhaps on future reports, maybe, or somewhere in the agenda, to kind of, I don't know, flesh that out a bit more in terms of what are the risks in terms of keeping to that level, because it's a kind of balanced scorecard, isn't it, really? And we could lose that if we're not going to keep our eye on it. So I think it will be useful for us as a board to be better, may I say, better sighted, perhaps on both where we are, where we might be, and what are the kind of risks that might cause that grading to be reduced. And in the reverse, in the sense that the NOF grading, it's kind of in the way you'd expect it to be. We're kind of in the middle of the pack, slightly better than the middle of the pack. We're grade 2, I think, aren't we, on that? And again, it has really big impact on trust if you lose those kind of good positions, because suddenly you're under much greater scrutiny, which takes a lot of time for the execs to kind of deliver. So not only is it good for patients and good for our own kind of self-esteem to be in a good place, but actually if we lose those gradings, it has significant impact. So I think it'd be nice to maybe have a bit more focus on that in terms of the reporting. It might even I don't have a think about it, but it might even be a separate item, perhaps we might just put on the agenda, because strategically keeping ourselves in these places is really important. And for board, I think we need to be really sighted on whether we feel solid in those gradings or whether actually we're kind of on the borderline, and whether they're at risk. The other thing I wanted to make reference to, if I may, was around joint working. Again, you've made reference to it, thanks. And I just wanted to be specific about it, because it's really encouraging. And I was just kind of looking around the table, actually, looking at all of the execs. And I think without exception, everybody sitting around the table here on the exec side is working really well with their colleagues in SCAS. I mean, Peter, you're working with Becky on a whole number of things. And Nick, I know, Nick, there you are, Nick. Nick, I know you're working with Craig on CAD and IT. Jackie, I know you're working with your counterpart. Jerry, she was here, she knows doing the same thing. So actually there's a lot going on. And Sarah, I'm sure you're working with Danny as well. So there's a lot going on at operational levels. And I just wanted to reflect that and to say thanks for doing that. And it's the embodiment of the group. And we kind of think about the group as being something that, boards and all that kind of stuff, but actually underneath the boards, there's a huge amount of joint working going on to help us develop consistent approaches. So big thank you for that. 2 other things I briefly wanted to mention, if I may. Seasonal pressures. One of the things that strikes me very much, just to slightly expansion on the heat issue, is that I know certainly in the last 4 years in Wales, we kind of at various times we talked about in the ambulance trust, we talked about taking a breather in the summer and then you get the winter pressures. Actually, what you see is there is very little seasonal variation in demands now, and we just need to be kind of aware of that. That you've got the winter pressures, but you've also now got summer pressures. So it's very hard to find an area.
It's just a resilience plan.
Absolutely, yeah. It's consistent all the year, but for different reasons. We just don't get a downtime now. And I think that's important in planning, because a lot of planning has previously been kind of thought about in terms of implementing things like system changes, or we can't do it in the winter because we'll do it in the spring, or we'll do it in the summer. Actually, I think that those kind of opportunities to do, Nick's nodding, those quieter opportunities to do these big things or probably gone forever. And actually, whether you implement in the summer or implement over Christmas probably makes little difference these days. And the final thing I wanted to mention as well was can I just publicly give a massive shout out to a group of people who I've got a massive love for, and that's the volunteers. And we haven't spoken about volunteers today. And I wonder whether either Jen or maybe from a governor's point of view, we could actually make sure in future boards that we actually have some kind of input about volunteers and what volunteers are doing. And can I ask, is there a volunteers conference coming up?
I don't know about the volunteers conference, but the community resilience strategy is the volunteering strategy. It's probably a terminology differential.
Okay.
So the conversation about Good Sam and community resilience was about volunteers. I should have been clearer, apologies. And so the desire is to bring something really focused about that work alongside with the cardiac piece, because clearly volunteers help us in a whole load of framings beyond cardiac survival, but that is a really important role for volunteers.
Okay.
I'd very much like to do that in the next few months.
That would be really good, because I think the volunteers have a massively important part to play, and a really significantly expanding part to play in the transformation of the ambulance service generally. And if you think about falls, for example, getting hands on quickly. I know cardiac arrest is really important, but actually it's a tiny part of what we do.
Yeah.
More and more we're seeing, frail elderly falling. We're seeing people with injuries where they have to wait for ambulances. We're actually having somebody there at the time. In terms of virtual care, having volunteers with a patient able to feed back to clinicians in a contact centre is going to become a really important
We're also
aspect.
engaging them in the health and wellbeing, the workforce part of things as well. So, Colin, I'll send you the community resilience strategy that we signed off, so you can take a look at that. And I'm really welcome to bring something back on this.
Okay, and maybe I'll come to Hamilton in just a second. I know that in SCAS there's a volunteers conference on a Saturday in October, which I will absolutely be at. I would imagine there probably is one. People do tend to have these kind of day events. But
we had one last year. I'll double check.
Could you do that?
Yes.
And can we circulate it to Ned? Because I think it's really important that we give volunteers every possible positive stroke, if I can put it that way, in the way you know what I mean by that, because they are such an important part of what we do, and they just do amazing work.
Colin, just to let you know, certainly on the next People Committee agenda, there is an item around the volunteering strategy, and that's really sort of to review implementation as well as in terms of how we're supporting our volunteers. So it's something on our agenda.
Good. Okay. Thanks very much. Thanks, Jen. Now I'm just checking on time. Not only did I commit the first cardinal sin of getting Mojan's name wrong, I'm going to blame my varifocal glasses, but that wouldn't be true. just incompetence. Second level of incompetence is we're actually running about half an hour late on the planned agenda, because it might not be my incompetence, it might be your inaccurate guessing as to how long people will take. Whichever it is between us.
I'll take it.
We're in a no blame. So let's not go there.
Yeah, probably right. Yeah, exactly. So anyway, we are half an hour behind. So look, what I suggest we do, because the plan is to take a short break now, almost exactly now. So let's do that. Let's take a 10-minute break. That will give ourselves 12 minutes and get back here at 20 minutes to 12. So a quick 12-minute break, and then we'll crack on with patient story. That's okay with you, Richard, because you're next on the agenda.
Yeah, and Kieran.
Yeah, and Kieran indeed. Yeah. Good. All right, let's do that. So back here, if we may, in 12 minutes' time. And we're going to move straight then on to the board story and to Kieran, who's going to introduce it. Kieran, over to you.
Thank you very much. And it's a great privilege to be able to bring this story to the board today. I need to warn you in advance that it is a genuinely very upsetting story I'm going to be sharing with you, but a really important story to share. So, Oliver is described by his family as a fit, healthy and popular 17-year-old. He lived with his mum, his dad and his younger sibling, Flynn. On Saturday, the 20th of July, he just reported feeling tired, but otherwise well, and he'd been on a trip to Thorpe Park. On the evening of Sunday, the 21st of July, Oliver started to suffer with a headache and felt sick. By early afternoon, on Monday, the 22nd of July, Oliver was seriously ill with a non-branching rash covering most of his body. His parents called 999 requesting an ambulance, and despite Oliver's parents trying to explain what was wrong with him, the incident was unfortunately incorrectly triaged and resulted in a non-ambulance outcome. Oliver, however, was taken to hospital by his parents, where sadly he later died that evening. The CCAM patient safety team became aware of the incident following a review by our trust safeguarding team. Subsequently, the case was reviewed at our internal incident review group, and a patient safety investigation was commissioned. So following the commissioning of the PSII, the investigating manager took immediate action to reach out and start engaging with the family. Over the course of the investigation, a really strong positive relationship was built between the family and the investigating manager. The family appreciated the honesty and transparency displayed by us as a trust whilst undertaking the investigation. And this reflects one of the key requirements of our patient safety incident response plan, which is compassionate engagement with those affected. The PSSI found that there were issues within the Trust's call handling processes, with a lack of understanding around escalation routes available to our 999 call handlers. Following completion of the PSSI, several recommendations were made. These included commissioning a working group to review the care pathways for patients presenting with multiple symptoms. And this group had been the enabler for several significant changes within our call handling processes subsequently, which I'll explain later. Some other recommendations included increased sepsis awareness within our integrated care, so our Trust's contact centres across 999 and 111, with the Trust implementing a sepsis awareness week. Also, within the recommendations was for the Trust to review and consider the use of artificial intelligence to support call handling, and for the Trust to raise concerns with NHS Pathways, the provider of our triage software, regarding patients that present to us with multiple symptoms. Now, in a few moments, we'll hear from Oliver's mum, Susie, directly. This video is 6 minutes long. So particularly for members of the public who may be watching this recording, there is a trigger warning here. This is a very emotional video, which Susie's very kindly been very happy to share with us today. But it will bring thoughts regarding emotions that you may have encountered in your own lives and in your professional lives as well. So we'll play the video now, and then we'll come back to myself. Thank you very much.
It's ripped our family apart. We had a 4 and now we're a 3. You know, our lives will never be the same ever again. It broke us. Oliver was gracious, beautiful, just a very kind, warm-hearted individual. He had just recently turned 17 and had gone to Thorpe Park the weekend, the Friday before he passed. And he complained of having a headache. So I gave him a paracetamol, and he went upstairs for an early night. And I went in and checked up on him in the evening, and he just said he was feeling very tired and shivery and cold. So I felt like I just kept going up and checking up on him, and he wanted to sleep. But it wasn't until about 2 o'clock that I went in and he was awake. And he said that he had found a rash on his body. So I got the glass, because straight away I assumed that, you know, a rash, get the glass. So I tested it and it didn't go clear with the glass. So I called my husband, who was outside, and we called 111. They said to call 999. I feel that the call handler could have had more empathy. From the start, you felt like a bit of a number. And the questions being asked were just being, I guess, read one after another. But also as a parent, we're not medically trained. We don't know what the main symptoms are. So when the call handler kept asking what was the main symptom, all we could say was he was 17 years old. You know, I can't, my child's unresponsive. He's just lying there. He has a rash all over his body that won't clear with a glass. He can hardly talk. He's been sick. He had a headache. I think he has meningitis. So at that point, you just assume that an ambulance is going to get called. The reply we got was, I'm going to put you on hold. So we later found out that when the call handler put us on hold, the person went, I guess, to level above. But during that call, never once did the call handler relay back what we had said. All the person said was, the patient is tired and drowsy. Is there a sepsis pathway? Never once did they mention that he's 17 years old, that we think he's got meningitis. He mentioned that there's a rash that is unclear. But we said there's a rash that doesn't clear with a glass test, because as a parent, when you think your child has meningitis, that's what you think the main symptom is. A few minutes later, the call handler comes back onto the call and says that we're going to expect a telephone call. At this point, we were we couldn't believe it. You know, we just assumed that they said an ambulance is going to come. So our first question was, when are we going to expect this call? And the call handler said as soon as possible. What does that mean, as soon as possible? 5-10 minutes must have passed. And my sister's a paramedic. I called her and I explained to my sister what the symptoms were and what was happening. And my sister said, don't wait, just go. We got Oliver to East Surrey Hospital, which in a blue light situation would probably take 15 to 20 minutes max. But for us, it took 45 minutes or so to get there because we had to get through rush hour. When we were there, it must have been, we found out actually, it was 82 minutes later, the clinician or someone from the emergency services called us back. But at that point, Oliver was in a bed fighting for his life. I won't allow my son to die in vain. This is going to be Oliver's legacy. I would like these call handlers to be able to have the confidence and the training in place that they can distinguish between sepsis, meningitis. I'm hoping that by telling Oliver's story, we can make a difference. We can make a change. You know, adequate training will be put in place so that when a similar situation arises, the same mistakes won't be made as they were for us.
So, as Susie has quite clearly articulated, that whilst Oliver's story is tragic, the important thing for her and her family is that we've connected this to some positive action. So Oliver's story was the catalyst for a wider piece of work across the Trust, exploring how we respond to patients presenting with multiple or non-specific symptoms. Following patient safety incidents involving presentations such as sepsis, meningitis, acute coronary syndromes and maternity complications, a multiple symptoms task and finish group was established to better understand the risks, barriers and opportunities for improvement. The group brought together a range of perspectives, including patient and family experience, frontline staff insights, clinical expertise, operational learning, and pathway and audit information. And together, these insights helped us to understand where our systems, processes and culture were creating challenges for both patients and staff. The review that we undertook actually identified 3 key themes. So patients with multiple symptoms can be at increased risk. So existing processes were not always designed around presentations where there is no single clear main symptom. This could result in delays in escalation, early exits from NHS pathways, algorithms, and inconsistent access to clinical support. The second theme was also staff needing to have greater support to escalate their concerns. So feedback highlighted uncertainty around when and how to seek clinical input. When we did baseline surveys of our staff, there were concerns around challenge, confidence, psychological safety, and how these can create barriers to escalations. And thirdly, the system needed to enable safer decisions. So learning highlighted opportunities to improve policy, training, and clinical support pathways and system design. So the learning from the patient safety incident investigation and the multiple symptoms task of finish groups informed a combination of policy, cultural and digital improvements designed to support safer escalation and more timely access to clinical decision making. So one of the most significant changes has been the introduction of the intelligent clinical queue. This is, instead of clinicians selecting calls from a visible queue, the system now presents the next appropriate instance based on the patient's prioritisation. This means that higher risk and longer waiting calls are brought forward and more consistently, reducing reliance on individual judgment alone when selecting work. EOC contact centres went live first, and the wider trust rollout for virtual care and our field operations colleagues took effect from the 6th of July. Early operational feedback is that clinicians are increasingly focused on the oldest and highest priority patients awaiting review. So although we would be clear that this reflects early operational learning rather than a form evaluated data set at this stage, it certainly is a positive enhancement into identifying patients such as Oliver. Alongside these digital improvements, the multiple symptoms work continues to move into frontline practice. So trust-wide communications, training materials, decision support and audit arrangements have been implemented to help staff recognise presentations where there's no clear single symptom and ensuring patients receive timely clinical input when concerns exist. So this demonstrates the learning has not remained within governance groups or with investigation reports, but is actively being translated into day-to-day operational practice. The next phase is to continue to strengthen the systems in place. An example of this is through developments such as skill-based allocation, further refinement of the clinical prioritisation elements of the intelligent clinical queue. The key message is that patient learning has influenced policy, culture, training and system design, and we now need to continue to monitor whether these changes deliver sustained improvements in patient safety over time. The work has continued and is continuing to inform a design and linking very much into the future of virtual care model. So as I mentioned, some further intelligent clinical queue development will include automation of identification of high-risk calls, routing of complex calls to appropriate clinicians based on skills mapping, and just load balancing between queues across the trust to ensure timely responses. Pushing more complex calls to senior clinicians. Next slide, please, Richard. So this work has demonstrated the value of combining patient experience with staff insight and improving methodology to identify and address patient safety risks. The trust in collaboration with SUSI is currently exploring the development of an e-learning module focusing on recognising and responding to patients presenting with multiple symptoms. As previously stated, learning from this instance is being fed into development of our virtual care model. What's really important for us is sharing this learning transparently, not only internally within our organisation as I've described, but also nationally. So we took Oliver's story to AACE and we shared it at QI Guard only last month. We've shared it on several occasions at NHS Pathways user groups, and I mentioned in there about how NHS Pathways were approached initially and have taken great interest in this story to try and provide further enhancements in managing multiple symptoms within algorithmic triage protocols. Importantly, due to the work that we've done in sharing this nationally, is that you'll be pleased to know that under the group model, our colleagues in SCAS are taking exactly the same approach that we've outlined as well. And being able to support them through that process is really key to us as next steps. Oliver's story continues to remind us that every patient experience provides an opportunity to learn, improve and design safer systems for the future. And if we can continue to use examples like this as best practice of how we learn from these incidents, then for me personally, I feel that's the exact journey that we should be on. Finally, as a trust, we'd like to take the opportunity to genuinely thank Oliver's family for sharing his story with us. This has not been easy for them. And thank you particularly to Susie for all of her incredible work in this space. We very much value their continued support in helping us to learn and improve. And thank you all for your time today to listen to me.
Good, thank you, Kieran. As you say, very hard watch in some ways, but it does just remind me particularly how the ambulance service is evolving to be much more clinically led, and how actually having clinicians in contact centres. And it also reminds me, Nick, that the work of AI and the way in which at the moment, quite rightly pointed out, the call handlers do have to go through a set of standard questions. And I was watching one only last week in a contact centre where the caller was desperately trying to get the call handler to talk about something that the call handler didn't want to talk about because the questions didn't allow the call handler to talk about it at that moment. And the conversation was incredibly disjointed and was actually quite a difficult listen in some ways. So I think it puts into context, it doesn't provide any answers, but I think it puts into context the way in which we need to evolve a lot of what we do, because we are expected to be a clinically led organisation, not a conveyance led organisation. But let's open the floor to anybody who wants to make any comments or questions about it. There's quite a lot of this connects with other things we're going to be talking about in terms of virtual care and also culture, actually. Liz.
Thanks, and thanks, Kieran, and thanks to Susie for sharing, because I mean, I understand how really distressing that must have been. I think also from a governance perspective and PSERF and PSERP, without the structure that we have in place now, we wouldn't have managed to get the changes required for our patients going forward. And I think that's the huge learning out of this, that this initially was a safeguarding and then it was a formal complaint to us as well. And we've now managed to use that to change not only the way we work in CCAM, but across the board in terms of ambulances, call handlers and NHS Pathways that we knew we had concerns about, but for NHS Pathways to actually see this from the patient perspective has made tremendous change in the way in the future we're going to respond to our patients. And yes, that linked to virtual care that I know we're going to focus on. So I think this has made dramatic improvements to how we will work going forward. And thanks to the team and the family, especially for helping us to do that.
Seems to me also that it's quite an object lesson in how much positivity you can get out of handling these issues professionally and properly. I have seen, and I'm sure other colleagues have seen in other places, where sometimes defensive responses and perhaps slightly less fulsome responses actually make situations worse. And actually what most people want out of these circumstances of tragedy is something positive coming out of it, and they want a positive and open response from the NHS, whether it's a trust or an ambulance trust or any other NHS body. And I think it sounds anyway so we handle this incredibly well, with immediate openness and a willingness to accept that there were mistakes made and there were system issues that we needed to address. It wasn't just a human issue. Actually, the systems issues caused people to behave in a particular way which didn't help.
I mean, most of the time you hope you don't have to call 999 or 111, but actually because they are going through a fairly scripted process, when you're on the receiving end, you are having a cross conversation and I'm just wondering what more we can do to be able to get people to understand that there's a method that people are following in order to be able to get the right outcome. Because very clearly through that conversation and through other conversations, and I've personally experienced it, where you are getting frustrated because you're not getting to the heart of the conversation that you think you should be having. And I'm just wondering whether there's anything more we can do in terms of that proactive, getting people to better understand how that process works. Because normally the first time you come across it is sadly when you make that call. And that's most probably the thing that's sort of going through my mind. And then the other part of it is that, you know, very clearly there is a criticism of the call handler. And it's also about what are we doing about the individual and supporting them through that conversation. So Kieran, maybe just a little bit around that.
Yeah, thank you. Thank you so much. So first of all, I think that's incredibly important around acknowledging to the public of how accessing emergency healthcare is not necessarily what you would see when you watch EastEnders and you dial 999. And I think that's incredibly important for us to, and it's weaved into our virtual care strategy about engagement with partners. Of how to do that. I also know that nationally, AASA are also very interested in how they can better support us as providers to be clear on that messaging. Regarding the second point, with the call handler, you know, I think this is really important as well to draw comparisons to perhaps how organisations might approach these type of situations historically. That call handler, as part of this process, was very well supported and continues to work within our organisation, and it has been part of the improvement journey for us, and it has given that feedback, which we're incredibly valued to have. This is very much, as I've articulated, system learning. But we do have to use humans to make decisions, and humans are not invaluable, and supportive technologies I think will have a place when safe and appropriate to be utilised. So for me, there's a statement which we use in primary care, which clinicians amongst us will be familiar with, which is the golden minute, allowing the patient to explain what the problem is. They generally tell you the diagnosis, what they need. We can't afford to have a golden minute in a 999 call for the patient just to explain everything, but we probably would be able to capture that first 30 seconds or so of when we do give them an opportunity to then revisit what they've said and highlighting key. So really exciting developments coming along the way. But I think that the key message from me is that through this and others, we recognise that we needed to make small but meaningful changes across a variety of different areas to really try and reduce any sort of recycling of what we saw in this case.
Yes, and building on Kieran's points, I'd just like to say a few words about the digital technologies that are coming along the way. So we heard in Kieran's explanation of the actions we've taken, the intelligent call queue that we've implemented to use technology to prioritise and identify those calls that should be allocated and to allocate them more quickly to a clinician. That's a great move that we've been able to do in the last couple of months. Is making a real difference. It's speeding up the process as well. I think there's 4 levels of technology intervention here. The second level we are trialling at the moment, which is AI-assisted clinical audit. Now, this is a retrospective technology in that we are able to assess the call process and retrospectively review the accuracy of the clinical outcome that was achieved from it for educational and learning processes and for individual support and performance management. We can, and this is technology we're trialling at the moment, we can apply that potentially to every call that comes in. AI allows us to do this at scale, where previously an individual would have had to sit and listen to the call and make a review and a judgment on it. So we can do this at scale. I think the third level is another technology that we're trialling at the moment, ambient voice transcription. And what we're testing at the trial at the moment that's being undertaken by ourselves and London Ambulance and elsewhere, and also in acute hospitals, is to transcribe the call to enable more rapid clinical wrap-up at the end of the call, to be able to produce referral letters, etc., as part of the call. But another thing that the technology is developing into is to be able to highlight in real time towards the end of a call whether it's felt that symptoms have been missed, and sort of the red flags. Okay, the AVT has heard in the call these things, and that doesn't seem to have been captured or actioned, and so it can start to highlight those. That's a real-time intervention. And again, very exciting, but it's in early stages. And I think the stage in the near future that AI can do is AI-assisted triage, which is actually using AI to at least partially automate some of that current NHS pathways approach to be able to get quicker to the diagnosis. Now, that's technology that's not ready yet, but it's absolutely being explored. And at the speed of AI development, I think we can probably anticipate to see those sorts of tools becoming available in the next couple of years. So I think there's a real step that we will see digital intervention escalating quite quickly to support some of these problems that we see.
Good. Thank you, Nick. I'm conscious of time, so we probably take Paul's intervention.
That's a very quick one, actually. It's just, that's brilliant. When are we going to see the strategy or the plan behind that?
Yes, so we are currently drafting a data and AI strategy. We anticipate at the moment bringing that back to the board to see. It will go through Finance and Investment Committee and other platforms, other internal reviews in the autumn.
Brilliant.
AI is a big key part of, where do we prioritise, how do we use it, what policies and controls do we expect to put around it will be part of that process.
Great, thank you, Nick. It does give a window into the future, doesn't it? It's about what a modern call centre, contact centre, ones and nines might look like in 5 or 10 years' time. Very different, I suspect, to what it looks like today. Okay. Thank you very much, Kieran, and I'm sure you'll pass on, and Peter, you'll let us pass on in all the proper ways to the family our thanks, and sincerely many thanks for being so open about that. Good, let us move on. So we've got less than an hour before we need to break for lunch, so we're going to need to move through the next sections fairly speedily, if we may. We have touched on quite a few of these items as we go through, so we want to make sure, if possible, we don't kind of repeat those. We have got two sets of PowerPoint slides, which are included in the pack, one for the BAT and one for the IQR, which will no doubt be referenced during these next three blocks of items. First item is about sustainable partnership and Finance Committee report. So we're going to go to Carl then for an update on Finance Committee report.
Yeah, just so I now will be chairing this meeting report. I didn't actually chair this one, but I'm more than happy to. I was there, so you're more than happy to give the update. I'm going to rush through a little bit because we have touched on all this, or are about to touch on what's in here. I'll probably just highlight very quickly a couple of things. One is the focus on non-recurrent versus recurrent savings, which we will be touching on, but of course that builds a risk for next year if we don't get that balance right. The positive news around digital transformation, actually Nick's just highlighted some of that, and that we had already therefore requested that we do start to see that strategy come, but equally around the governance arrangements for AI. It is moving very quickly. It's an area close to my heart and experience, and we therefore need to make sure that we have the right governance arrangements for it. It does require a different set of thinking than perhaps more traditional digital transformation. And then just in the advice area, we should draw attention to the Nexus House project closure and reflecting how well the Nexus House, as they sat in it, project went and how effective that was run. So that's a whiz through.
Great. That's fantastic. Thanks very much. And then we're coming on to the recovery plan actions, I think, is the next item. Simon?
Yeah. So slides I'll take as read. So again, in the interests of time, just to pull out the main points. These slides sit in a cycle of business. So we've been working on these from sort of October, November last year when we started planning for the next 3 years. Last time the board will have heard an update on this was in July in the informal session. So this is now our formal view of where we got to based on data this year to June. Our plan, 3-year recovery plan, recovering an underlying recurrent deficit at a steady rate over 3 years, whilst maintaining improvement in C2 response times to 18 minutes, predicated on an increase in virtual care. So that's in a nutshell. So what the 3-year plan, what our strategy overall is seeking to do. So these slides hopefully segue into the conversation very much about virtual care. So if virtual care has been on the stocks for the last 2 and a bit years, where have we got to with it and why have we gone further? And then that moves us into culture. So I think that's the sort of area we need to start thinking about as a board in terms of where do we take these improvements now. We've kind of come through some of the really easy stuff. Like 2 years ago, we looked at how we were contracting for things, we were doing procurements. We can take out some of these non-recurrent spend, these recurrent spend areas, non-pay areas. What we're looking at now is changing the way the organisation runs and thinks and operates, and that's more difficult. But that's the place we are. So that's really the context for these slides. So you mentioned earlier the conversation we had at the beginning of July with the National Ambulance Team, so NHS England. Important for us because these people are in control of £10 million a year of revenue funding to us for the next 3 years to improve C2 performance from where we had it last year, 28 minutes down to 18 minutes. And we aren't funded for activity growth. We are funded to improve our performance. It is anticipated that we improve our productivity. So those are treasury metrics that we are working with. So the conversation with NHS England was really important, good staging post for the rest of the year, and some of the slides we'll come on to. What they can see and what we need to remember is that compared to this time last year, our incident growth has gone up by about 8%, but our C2 response time has improved, and we have no more people or vehicles to do that with. So there has been a significant improvement in productivity. Alongside that, there hasn't been a significant growth in harm. So we are doing really, really well. The NHS England people can see that. Now, the way they think about it is there are things that you can control, and they distill that really neatly into, and we can see you are doing everything to control the things that are controllable to you. And in their mind, there are things you cannot control, and they are beyond your control. So things like demand growth, things like handover delays at acute hospital. Now, internally, we know there are things we can do to manage demand better than we do now, and there are more things we can do to help partners with delays at ED. However, not in our interests in that national conversation to disabuse people of that notion, because as we sit here, they are very well intended, very minded to give us all the money, the additional £5 million in October that our plan is predicated on, if we just keep doing the bits that we are in control of. So I think that's an important context for us to be thinking about. Because when you look at the third slide, there's a sea of red off track on a lot of our trajectory. So we thought we would be a lot further forward on C2 performance than we are. The idea being performance in the summer when it's quieter to prepare for winter. What we've seen from the summer, of course, is that it has not been quiet. 4 heat waves means that it has been busier in some cases than winter. So we aren't where we need to be, C2 money for virtual care, but there are reasons to be optimistic and to celebrate the fact that we are being much more productive as an organisation, and we can clearly track the improvements we've made. Important that we keep focused on the things that we've said we were going to do, though, because of the interplay between recurrent and non-recurrent change. Come on in a couple of minutes to slides which say, broadly speaking, I think if we can keep going in the way we are at the minute and things get no worse, than money in C2 might work. Virtual care becomes an issue. Fourth slide, again, NHS England really liked this slide because what it seeks to do in analytical terms is to demonstrate that the bits that are within our control are internal factors. This is where really, really close to the trajectory we set ourselves. The external factors, excess demand above plan and the handover delays, that's really what's driving the adverse performance away from trajectory. Slide 5, you can see all of the things we are trying to do, and there is a majority of those that are off track. So again, we are not where we need to be. Operating plan, I won't dwell on that. We talked about that along with the delivery roadmap, but I will then finish on the summary slide, which to summarise says really we're not delivering the recurrent cost improvement plan that we set ourselves. If that position does not worsen from the month 3 forecast outturn, I think we will be okay to deliver a break-even plan. But that stores up a problem for next year that we could do without next year. We'd be even better if we could move further on that recurrence, but it would not sink the ship if we didn't do it. C2, if we can keep doing what we've been doing around job cycle time and dealing with the activity above plan with no more people, NHS England will continue to support the plan. We will keep ourselves into that tier 3 of risk escalation and oversight. We will get the £5 million performance fund, and ultimately we will be responding more quickly to patients than we did this time last year, despite the activation goals. Virtual care, however, is much less clear. Why are we not further ahead on virtual care? All of the efforts, all of the explanations, all of the strategy, all of the clinical engagement, all of the engagement with partners, all of the engagement with the team. Why are we not further ahead with this? Because virtual care really underpins the entire strategy. If we can pull off virtual care, then C2 will improve. The way we spend our money will improve. So we have to ask ourselves, why is virtual care not amenable to the explanations we've given and the exhortations to people to do more? Why is it not working? And I think that then does segue neatly into that culture piece, because I think we've done a lot of the ground clearing work. We are now into the more difficult areas to affect change in, which is that culture. So I think, without dwelling on things, but leading hopefully neatly into the next 2 items on the agenda, being virtual care and culture. Those are the things that we wanted to focus on the board today.
Thank you very much. Let's give you a bunch of time. Thanks very much. clear expression of where we are. Come to a second. Clear expression of where we are. Let's not have discussion about virtual care and the open questions that have been answered, because that is on the agenda. We're going to come to virtual care specifically. So let's park that until we get there. Some of the cultural issues, it's on the agenda. So let us just concern ourselves at the moment, if we may, simply with statements of where we are in terms of financial position, the information we've got about how we might be going through for the following year and so on. So is that okay?
Of course it is. Thank you, Chair. Thanks, Simon. Just one question, really. So I've noticed from your finance report, there's quite a lot in there about workforce. We seem to be in this position. We've got some vacancies in 3 directorates, some overspend in some other directorates. So it's made me ask the question about where are we on the workforce plan, because we keep saying that we need to do this workforce plan. When I read that report, I thought, actually, this just highlights me the importance of having a workforce plan sooner rather than later. I just wondered if you have any information on that.
So I would encourage us to think far broader than the workforce plan. I think we need to better integrate all of our planning. So no point having a workforce plan if we haven't got vehicles to put them in. And a lot of the time we respond is with despite virtual care, need to do more. So I think I would still look at our planning and think there is an opportunity for us to better integrate workforce planning with vehicle planning, with make ready planning. We don't do that sufficiently. We haven't done a rota review for quite a while. We are going to do that. I think workforce planning is a key part of that. But again, I was talking to Jackie yesterday about how do we integrate our thinking around workforce, how we dispatch, how we can use clinicians in virtual care to better inform dispatch, and how we can use that to construct a fleet strategy which says, do we need 430 double crewed ambulances, all with a monitor key defibrillator in the back?
Sorry, can I just point out, we get into a lot of detail here. I think it's a good question. Can we leave that perhaps to be answered in another time? Otherwise, we're going to get bogged down into some detail, which is I think not relevant. Jen, you wanted to?
It was fine. It was literally just very briefly to build on Simon's presentation, just so the board's got an absolutely clear understanding of where we are, framing the further update that we'll bring after our next review. So financially, we are still working well, but over-reliant on non-recurrent actions. So we need to be really clear on the delivery of as much recurrent financial efficiency as we can. And on C2 performance, we are, as Simon said, doing better than last year, but not nearly as well as we planned to do. So we committed to deliver a 25-minute mean within the existing financial resources and allowing for a 4% increase in demand. We've seen an 8% increase in demand, so 4% more than planned, and that has had an impact. But we have also not delivered on any of our key productivity schemes that are set out here on slide 4 of the pack. So the critical task for us over the next few months is to accelerate delivery of those productivity schemes in order, Simon has said, to safeguard the position as it stands, net of that excess demand. So it's really critical that we do that, and we'll be coming back to discuss further depending on how we get on over the next couple of months.
Good. Okay, thanks so much. Did you want to come in?
No, it's an ongoing conversation around workforce planning. I mean, that activity is constant, but actually it's also about identifying actually the size and shape of the organisation. So certainly input from our clinical leads in terms of what is it do you require, can you then only sort of start thinking about actually how you're going to fill that demand. So it's we had some of that conversation at the people committee. So just to sort of, it's not something that at Subo that we're not talking about on a regular basis.
Sure. And of course, Simon makes a really good point that it's not just about work planning; it's about planning properties, because it all interconnects. As you've made the point, no point having a workforce you haven't got vehicles to use and so on. So it's all a multi-layered kind of thing, isn't it? Good. Okay. Can we, in that case, if we can move on, just checking that. We're happy to move on to the next item, which is about how we deliver the high quality care. We're going to go, Liz, to you just briefly for a summary of the committee meeting, and then we're going to spend some time on the virtual care model.
Yeah. Great, thank you, Colin. Just say, obviously, Bathurst 1, I'll take the paper as read, is virtual care, and we're going to get a response from Jen on that next. We had escalated concerns from the committee around patient access, patient outcomes, and C2 response, but I'll leave that to Jen to respond to. We did look at a huge amount of work's being done by Joe and the team around health inequalities. That's really moving forward, and the work that's been done to look at quality and equality impact assessments. It was great to see that at the committee and the work that's been done around that. I think also around quality improvement from an assurance perspective. I think we're also quite concerned about our C3 and C4 responses. We focus on C2. We have many hours of waiting by our patients in C3, C4. And we spoke about that in the context, as you said earlier, Colin, around the utilisation of our CFRs and our volunteers and the work that's actually underway to ensure better dispatch of our CFRs, including via automation that's now been put in place. So again, AI systems, etc., have really improved the dispatch of our CFRs. So we accept the challenges given resources and demands, but we are now starting to see improvements that at least our patients are being assessed by someone during those long hours of wait. And I think overall, we will cover everything else in other items on the agenda.
Thanks very much. Of course, those long waits in C3 and C4 depend upon having the diagnosis or the triaging process correct.
Yeah.
Fine. In that case, if everybody's content, just any particular questions on the committee issues before we move on? All roads apparently lead to virtual care. Our future, our entire salvation is dependent on virtual care.
Yes.
How are you going to do it?
Colin. Yes, I mean that is both a nice, simple, but perhaps slightly dangerous framing for it. So I think virtual care has perhaps the same challenges as a little bit apparent in the workforce discussion that we, can follow up another time, which is that we need to be planning and delivering in the here and now at the same time as planning and delivering for a future state. And holding the horse of the here and now with the horse of the future in a kind of perfect unison is not necessarily an easy task. And I think that very much applies to both workforce and to virtual care, and they're not unrelated, of course. So I'll run through very briefly the future model of virtual care update for the board, but I'll recognise also as I conclude the here and now problem of increasing our resourcing, improving our productivity, enhancing our practice and delivering here and treat rates through the period that we're implementing this model, which remains, as we've said, the here and now challenge. So I think we have discussed this on a number of occasions previously, that the reason for evolving our model of virtual care to the new future target operating model is because we've learned a lot from what we've done so far, but we have a distributed, or one might even say fragmented, system in place at the moment, which doesn't allow us to be as consistent, as replicable, as constant best practice delivering as we would wish for our patients. And we need to consolidate and learn from all of what we've put in place through the 2 EOC virtual care operations and our 10 hubs to create a kind of a future model that is more consistent, more resilient, can be scaled and enable the level of virtual care that we require, while ensuring that we continue to kind of work with both our patients and our workforce to deliver that in a way that makes sense. So we're talking here in virtual care about both what we call pre-dispatch and post-dispatch virtual care. So virtual care happens in two spaces. One is with the patient ahead of dispatching an ambulance to try and route people to the right care first time. And that's, I think, the kind of virtual care that our strategy very much focuses on. But there's also an important element of virtual care, which is around what we're calling joint decision making, which builds very much on the of our advanced paramedic practitioners to offer support, advice and best practice pathways, I suppose, to crews on scene so that we can get the right outcome for those patients for whom we do dispatch an ambulance. We have made progress actually over the last few months in defining the approved operating model more clearly in terms of the clinical process that we're looking to implement, which I think is a really important step forward. On slide 4 of the pack, we outline our newly created future clinical process, end-state clinical process. Clearly, there is more work to do to define the operational and clinical detail of each element of the process. But I think it's really important to draw your attention at this high level to the sort of 3 key or maybe 4 key elements. One being the initial call triage in the Emergency Operations Centre, and linking back the importance there of the clinical support desk, as it's currently called, or clinical inline support, which is something that was really importantly highlighted as part of Oliver's story. And it's something that we really want to sort of make sure that we're building the right capability as part of our virtual care operations, seeing that clinical support is very much part of pre-dispatch virtual care. Then we have the blue box, which is the pre-dispatch virtual care operation, centering around our 2 ICSs, delivering through a single governance framework, leadership framework and way of working, utilising those digital tools in an even more sophisticated version, again, than Kieran has talked to already, and making sure that we're being innovative in the roles, skills, capabilities that our workforce have in that system, and that we're working in a collaborative and networked fashion, that we're consolidating, not necessarily so everyone works like shoulder to shoulder all of the time, but so that there is much greater collaboration in that kind of system space for the virtual care clinicians to feel and in fact be part of a single team, working to a common standard and owning that patient care and the quality of that patient care that they're delivering. So that's really, really important. And then in the purpley box, if purple is the right colour, again, that's the joint decision-making piece of the puzzle. Really interesting work going on there to look at the future clinical process, where traditionally, we talked about this with Getting It Right First Time team yesterday. Traditionally, we've framed, and Michael put this very well, Michael, Deputy Chief Paramedic, he's not here, so I'll have to try and do it for him. We've traditionally focused on very much kind of the default for an ambulance service being when you're at scene, you're there in a truck with a paramedic and you take the patient to hospital, and our current support system is set up almost envisaging that there's a risk of leaving someone at home and you need to seek support to leave someone at home. Whereas taking someone to a hospital, there's no requirement to seek support at the moment. And thinking about how could we safely reverse that default so that our premise becomes very much about safely in an empowering way to using community partners to help somebody stay safe at home, because that should be the default for them. And that if we're thinking of conveying them, particularly to a high-risk environment like an ED, we need to think carefully about what support we can seek before we do that, and what alternatives we can access. So that's much easier to say and describe than it is to enact in practice. But it's a really interesting challenge for designing the future model, which is framed in that way. And then, of course, the fourth element being the access to those system pathways and those system partners. And at the moment, that's very locally dependent, like on, knowing the number of the consultant at Hospital X. And although there's value in some of those really fruitful local relationships, which we don't want to lose, actually what we need is more consistent clinical advice and access to pathways, and to be a trusted assessor, not dependent on knowing consultant X, but being respected in our own right as and clinicians within the urgent care system. So I've been very excited to develop the future clinical pathway further, and I think that's been welcomed by teams as we discuss it. Touching then on the journey forward, as you are aware, we have passed from the design to the mobilisation phase of this programme, and will then be working through 2 further phases from essentially now onwards. A first phase of implementation followed by a second phase of scaling and optimising the model. The first phase of implementation deals largely with the development of those detailed clinical processes, the development of new roles within the virtual care space and recruiting to those roles, making sure that we're building the digital tools that we need, and we're working through all of that in terms of its impact on both patients and on staff. And then in the second phase, we'll be delivering some more concrete scaling. So changes to locations or ways of working will be addressed in that second phase once we've had the opportunity to fully develop the process and to assess its impacts and the way that that change will be managed in a very appropriate and consultative fashion. We've had quite a lot of feedback already on the virtual care future model, and acknowledged that it's a difficult place to communicate because there's naturally a desire both for complete clarity and certainty on exactly how it's going to look in a year's time, but also full engagement, participation, the ability to influence. And in a sense, those 2 things are in tension. You can't simultaneously have fully defined everything and for people still to engage and influence what it is. So I recognise that as a tricky balance to strike, and we've learned from the kind of last couple of months that we haven't always got that exactly right. So we're trying to be clearer about what is and isn't decided and what people might be concerned about and what we need to do in response to that. And in part, that's really why we've got these 2 phases of the implementation. So we design the processes, the digital tools, the kind of ways of working, governance and leadership in more detail. And then we can properly assess the impact of those changes and enact the changes in an appropriate way. So I won't go through all of the staff feedback themes and responses, but that will be a continuing conversation. And as I say, it has led us to shape the implementation plan into these phases that are outlined here in the presentation. I think we're just touching at the end on what we're trying to achieve here, which is really the critical thing. Ultimately, better patient outcomes for more of our patients delivered in a consistent and scalable fashion. And for our people, a clearer, more fulfilling virtual care career pathway, I suppose, as part of our model. And this is where there's a critical interface with the workforce planning, because our workforce will look different in the future. I know we talked a little bit about it at People Committee, but we have been with Sarah, Jackie and others trying to better visualise the future shape of our workforce that supports these shifts in our virtual care, but also speaks to how we might shift our physical responses as we innovate in that space and think about advanced practice and partnership as well. So in summary, we've taken the next steps down delivering the board approved target operating model, developed the clinical process, thought through the phasing of implementation, and we'd ask the board to note that we've heard considerable staff feedback, and we've responded to that by adjusting our approach to delivery and support the ongoing work, essentially. Just before I finish, Colin, I'll just touch briefly on the question of here and now, here and treat rate, which is actually really critical to, if I could put it like this, not losing our licence to operate in the next 6 months. It's not the only factor. We have done good work to be resilient around demand. We have done good work on reducing job cycle time, although we have still got challenges in abstractions and other areas. But here and treat, as Simon said, is very critical to enabling C2 response and more broadly timely response to patients who need a physical ambulance. So I would urge people to work with us as we develop the future model to make both the future model as good as it can be, but also we'll do everything we can to bring people into working with us in virtual care now and being as productive as they can be with the tools that we have available. So we will continue to work on all of those here and now recruitments, both within field ops hubs at the moment, and also to the new virtual care clinician and virtual care practitioner roles that we're testing within EOC. So that is a critical dependency for us and remains a clear focus.
Good, thank you, Jen. So, any questions, comments to Jen on virtual care? The way forward, Phil.
Yes. We can't be the only ambulance trust kind of looking at this as a significant solution to the way forward. And I know there's kind of some natural coordination, but are we learning anything from other trusts also on this journey, whether they're both ahead or behind, doesn't really matter, it's kind of, and are we feeding back what we're seeing? Because it will evolve a bit, I suspect, as you kind of move through this implementation.
Yeah, and I mean, it has evolved a bit already. Essentially, we are shifting our model to be the ambulance trust standard. Most, if not all, other ambulance trusts run a model more or less. You know, of course, there are local nuances, but similar to the future model that we're aiming for. So in this sense, like the distributed model that we currently have is like more or less an outlier in the ambulance sector. So in a sense, we are learning from them in developing this model, and that was part of the kind of strategic review that we did when before we approved this model. But there's absolutely an opportunity still to learn from other trusts in how they're doing it. So we've started to engage across with SCAS, because clearly it's important not only do we learn from each other, but also that we have a congruent journey forward. You know, so much use if we're implementing X and they're implementing Y, that's going to cause confusion. But there are also some exemplars in the virtual care space. Currently, London is the market leader in hear and treat rates, but there are other trusts who we can learn from, and we will be doing that in terms of thinking about what have they done to achieve the most appropriate and the most effective outcomes. So, yeah.
Where is London?
25%.
Oh, there seems to be a glass ceiling for most trusts, around about the high teens.
No, it's all much higher than that, Colin. There's been quite a lot of progress now. I mean, there's a lot of complexity to hear and treat rate. It can mask a whole range of different things, like under the headline figure of hear and treat rate, some of which, you know, were more desirable than others, but ultimately, I guess, all of which avoid the use of an ambulance where it may or may not have been, where it wasn't appropriate, I suppose. So we are now, with the exception of, I think, Yorkshire and North East, who actually have strategies that sort of aren't quite focused on virtual care in the same way as the rest of the sector, particularly Yorkshire, I think. We are like the lowest deliverer in this space. Most trusts are now like hovering at the late teens, early 20s, and there's several trusts with 20% plus.
Yeah.
But it is a struggle, you know. It's not
that 20% seems to be almost like something to sort of burst through.
Yes,
That's
exactly. Yes.
I know in Wales it's the same, and SCAS is the same problem. The 17-18%, and it goes up a bit and it's down a bit.
Yeah, SCAS has been struggling a bit, but yeah. So London and South West are doing very well, and West Mid are traditionally a high deliverer here.
Be a good topic for a board development session to get into some detail. Yes.
Jen, thanks for that. Really helpful. Can I ask, in terms of strategic partnerships and alternate pathways, it's been a bit of a struggle for us, both with hear and treat and virtual care. If we don't take to hospital, what are we going to do with the patient? Are we getting more community buy-in around this? And certainly overnight was a big issue, that there was just nowhere else for our patients to go or support.
Yeah, I mean, I think it would be fair to say, and Kieran, do feel free to comment, that it's still a struggle to get the right buy-in and capacity from community partners, and we observe a very significant differential from where the buy-in does exist, and some partners who, you know, really proactive in the urgent community response kind of space, and others where, or most others in fact, where that's not quite the case. I think we slightly could take ownership ourselves of improvement by being more consistent in how we do things, by thinking about where we could simplify some of the processes of referral. And we also could take, this is a huge opportunity for us and one we haven't yet optimised, is to take ownership of using alternative pathways to ED when we do convey, so that we can get the patient a more appropriate setting for their care, and perhaps to explore things like the use of diagnostic facilities. And we talked about quite a lot of this with GERFT yesterday, didn't we? So I think it's still a challenge, it's a significant challenge. And it ultimately, I think we would be ill-advised to wait for someone else to solve it.
Yeah.
We should be focusing on the things that are within our gift. If community service has no capacity, there's no harm, of course, in continually raising that, and we will do so. But we cannot directly, per se, influence it. So we need to focus on the things that we can do.
Thanks. A really great question, and exactly what we were discussing yesterday with the team. Complicated, I think, to acknowledge the fact that the changes in the ICB arena recently have been quite disruptive to having some quite pulling those levers and having those conversations. But the main message was clear, is that we don't need more pathways. We need less pathways that are robust, feasible, clearly articulated, and what we all expect, what we see on paper, to actually be delivered in the real world. So some really good thinking to take forward, but just to be assured that everybody's on the same page in this space, that they want to get through. But I think it's an excellent point to raise, and we need to continue to pull whatever levers we can to influence our system partners.
Thank you.
Thanks. It was just sort of a reflection, perhaps, rather than a question, and thinking particularly around the national landscape from a proportion of hear and treat perspective. And I also noted the good figures that London showed, but I'm also quite conscious that a significant proportion of those patients are also redirected to an emergency department. So I think there is something about me for looking at both of those in tandem, because I think we want the best of both worlds. We want a really high hear and treat rate, but we also want to make sure that we don't inadvertently create pressures for system partners in the process.
Yes, thank you, and for all the work that's being done in this space. Complex issue. I know we've had conversations, Jen, about it should be simple, but then how come it becomes more complex? And I keep asking myself that question. I think conceptually, there seems to be quite a lot of buy-in in terms of the flow and all the work that's being done at the moment. What's then interesting is then when you supersede that and lie that in the here and now, as you call it, the difference that makes for people's working practices, etc. And we're back to culture again, aren't we? And so I guess there's a question for me around what are your degrees of freedom around how far you can go with this? On the one hand, conceptually, and two, in terms of recognising you're probably not going to please all of the people all the time. So, and my sense is that there has been quite a lot of noise around this idea of two central places and people going in them. And I don't know, there seemed to be a lot of concern raised from that through shadow board members. And I guess there's, a query from people or an expectation that, well, how far can we change what's already been decided? That perception. So
worth clarifying that.
Clarify.
Yeah, can I just say, very short time, really lots of really good questions there that we could probably spend an hour talking about. Yeah. So I don't think it's going to be very helpful to try and answer all those now if we can. I do think we need to spend some more time on this. But
Can I just clarify the point about the locations? Because that's the one that seems to cause inadvertently caused. I think has caused, frankly, a fundamental misunderstanding, and we've got to take responsibility for, although obviously not intentional, that's what's happened. So we have agreed that we will have 2 ICS-focused virtual care operations. There was never a proposal that everyone would move lock, stock, and barrel into a single location. There is and remains a decision that it will need to be the case that people working in that ICS level service will need on occasion to co-locate and collaborate. As part of, as we all are here in this room, valuing the face-to-face contact time and the common ways of working that make us part of an integrated and consistent service. The dates, times, ways of working, numbers of times per year or month that co-location will happen has not yet been determined and is subject to working through in the next phase. But the principle that me seeing you in person, enabling us to work effectively together, is agreed on and is important to this model. And what we have also established is that we will hopefully have a sort of networked arrangement where we have the centre at Crawley and Medway, but we'll have a number of other locations, fewer I think than we have currently, but sort of spoke hubs, I suppose, within the 2 ICS areas. Thank you.
So it's not an instruction that they have to pack their bags and go every day.
No, and we have tried to clarify that for the misunderstanding.
And I think it's helpful to restate that here. So
that's all great. Good. Just a brief comment from me. For us to think about, and I think we should have more time on this, but it just strikes me that what we as a trust and as a group, as a big group trust, is going to have to wrestle with are some really interesting fundamental questions, and you touched upon them in this transformation to get virtual care to be something like the 30–40% or whatever you might want it to be one day. Is we're going to have to embrace AI, which Nick was talking about, and I'm very conscious that you've got the here and now and the future. The here and now we know because we see it. The trouble with the future is that no sooner do we have a picture in our mind of what the future looks like, Nick comes and tells us that's all out old. That's history. It doesn't look like that anymore at all. It's moving so fast. So we're going to have to be very, agile, but we're also going to have to be prepared to take risk in relation to our adoption of AI and how quick we're prepared to do it and where we sit in terms of do we want to be a leader in it or not. Big strategic questions for a group board to wrestle with. Another big strategic question is risk, which really interesting about flipping that dynamic about is the default position to leave in the home or default position to go to hospital. And a lot of people will say it's more risky to go to hospital because that's where sick people are, where you will pick up illnesses and diseases. And for a huge number of people, the elderly and the frail and slightly confused, sitting on a trolley in a corridor for 12 hours is absolutely the wrong place to be. So, our whole default position is probably wrong. And somebody somewhere has got to be brave and say, we're not doing it anymore. But then you've got to be brave to support your workforce to say that we're behind you. And if you make a decision which ultimately proved to be the wrong one, we're there with you. Big issue on that. And then I think another big issue is that mix would be of the current contact centre personnel, workforce planning and clinicians. At the moment, the ratio of call handlers to clinicians is in a particular place, very much weighted towards call handlers. Probably for a clinical model, it's going to be weighted towards clinicians. That we can only do with a financial model which is limited, is by embracing AI and accepting the risks that all that might bring, because it's the only way we're going to free up the cash probably to invest in clinicians rather than the constant conveyor belt of recruitment and training and saying goodbye to call handlers, which just goes on month after month ad infinitum at the moment. So some really interesting but difficult questions that the group is going to have to wrestle with if we're actually going to drive this transformation purposefully into the future as opposed to the here and now. And the other comment I'll just make, if I may, before moving on, is really reflecting what Simon was saying a little bit about recurrent and non-recurrent costs and so on, all really important stuff. It seems to me that we've got to a point now in ambulance trusts where, by and large, pretty much every bit of cost saving has already been done. There's always a bit more you can squeeze out. But it's an ever-increasing problem with increasing demand. We're seeing, more demand. We're expecting 4%. It's actually 8%. Well, next year it'll be another thing. There'll be 9 foot of snow, or there'll be some other problem. But we just have to wrestle with demand just constantly. And the moment demand is outstripping, it seems to me it's outstripping our ability to make salami slicing of various things to meet that demand. How much can we do in improving sickness? How much can we do in improving abstractions? How much can we do by making our training more efficient? How much can we do by holding people on and trying to reduce people, people leaving the organisation and so on? You get to talk about all of those things are at the kind of optimal human level of efficiency. And yet still the tsunami of extra demand comes in every year. So the only solution, actually, in the next 10 years, is going to be this major transformation change. Lots for us to think about and to be brave about. Thank you. Let's move on into the final item. We've got just under 7 minutes to deal with it, which is People Committee. So Harbhajan, can we go to you for People Committee update, if that's the right place, and then our discussion and culture, much of which we've touched on today.
I'm going to take the paper as read, given the timing that we've got. In terms of sort of key alerts, we did touch upon the workforce model, and it's in progress and in development, and very much we're back onto the conversation. what's the type of clinical workforce we need, also in terms of where do we find them, what's the skill set we need, how do we sort of, track those. So those are the conversations. We've had a lot of conversation about the management of violence and aggression, so I'm not going to go through that in any way. There are some reforms around staff and mandatory training. Again, we're just trying to work through in terms of how do we provide the assurance that that's being provided. And then sort of lastly, that I'd sort of most probably want to flag up is that we also looked at the response to the Lord Mahon review, very much about adopting definitions around Islamophobia and anti-Semitism. But we were very, very clear that it has to sit within the context of actually any form of harassment, bullying, etc. is not tolerated. So a lot of conversation around that. In terms of delivering the operating model, I'm not going to spend any time. We did do a little bit more of a deep dive around sickness absence and certainly looking at, I think, the proactive aid, the development of the new policy, but also the sort of proactive management of the 100 sort of top cases, and that's beginning to start yielding some dividends. We are still away from where we had set our target around sickness absence, and that has a budgetary element, and we recognise that. So it is something that we will come back and continuously revisit. So that's a very, very quick. Yeah, that's very.
Thanks. Any questions to Harbour Jan in relation to the committee issues from Tent? Thanks, I think it's great. So we've got 5 minutes. It's a massively important subject, culture. So I feel awkward in a way to try and curtail it, but we should. We've got other things to deal with in the private board as well. We've touched on culture a lot through today's meeting. So I don't know who wants to lead off on giving us a bit of work on culture. So, Sarah, 5 minutes, and if we need to take a bit longer, we will, but let's see how we go.
Okay, thanks very much, Chair. So the board are asked to note the findings of the independent culture review. So that was commissioned in January 2026, and it's really part of CCAM's ongoing commitment to strengthening organisational culture and ensuring the trust is a safe, respectful and inclusive place to work. So I'll take the paper as read, but I'll just pull out a few points. So the review recognised positive progress in recent years, including improvements in leadership, visibility, openness, staff engagement, and the organisation's continued focus on culture. However, it also identified several interconnected themes that continue to negatively impact on the experience of some colleagues in pockets of the trust. So those areas were particularly around professional boundaries and misuse of authority, recruitment and career progression transparency, localised subcultures and safeguarding of students and learners. And I think the overarching sort of theme is around consistency of leadership behaviours, which we have touched on earlier. The executive team takes this review incredibly seriously and has accepted the findings, including that we will collectively own the findings and the implementation plan. The findings will be used to strengthen ongoing work to improve leadership accountability, psychological safety, a particular focus around professional standards and cultural consistency across the organisation. I wanted to formally note my thanks to all of those colleagues, members of staff who did come forward and spoke up and participated in the review. So I think really the findings reinforce our sort of the importance around consistent leadership behaviours that align to the trust values. And we did touch upon earlier the sort of key areas of focus. So that will be the implementation of the trust leadership framework, which was approved by board in June, looking at how we strengthen accountability. And that's particularly around our new organisational operating model and how we talked earlier about local leadership accountability and leaders feeling confident in the decisions that they make. Finally, I suppose the progress around the culture review will be overseen by the People Committee, and the board are formally asked to note the findings of the review and endorse the proposed approach, which is embedding the learning through the existing culture review programmes. So that's a summary.
Yeah, that's grand. And those of you who've had experience with culture reviews in other organisations, the other NHS organisation, will recognise all of these things. that, what we're wrestling with here is nothing new. It's something which is common to uniformed services. It's common in other NHS organisations, and it's just making the point that it's not, I'm just saying the easy stuff has been done. It's not easy, but the beginning of these programs is always a bit more straightforward because you're designing policies and practices and getting yourself together in terms of agreeing what you want your organisation to look like and defining your culture and your behaviours and all those things. And then, of course, you suddenly discover that you've got pockets across an organisation where these things haven't quite filtered down yet. And how do you get that down there? You've touched on all the ways we need to do it, the leadership framework and so on. So this is where the hard work really starts. And it's a journey. It doesn't get done. Any comments or questions to Sarah or anybody else? Arbitron, do you want to add anything to it?
No, I mean, we had quite a detailed discussion at People Committee, and this triangulates with other pieces of work that we've got, whether it's feedback from the student data in terms of actually mechanisms around reporting and actually the follow through. So there are a number of strands in train, and it's now really sort of keeping the momentum and then going back and revisiting it to see whether it's having an impact. I think part and parcel of that will be also our pulse surveys, just to say, actually, are we making a difference? Is the dial actually moving? So I think it's something that it's going to be an ongoing agenda item as we sort of begin to move forward. It has implications for a lot of the other committees as well, because actually, vector sickness and things like that, if we start reducing those things, then actually some of that's down to sort of actually if it's an environment you're not happy with, and quite often people vote with their feet. So, all of these things all tie together.
Lots of proxy measures, aren't there? You take sickness and loss rate and things, proxy measures for the kind of happiness that you want. So I'm very minded of a comment you made earlier on about, you want the workplace to be a place where people feel content and happy and enjoyment and so on, but there are times when you don't.
It can't all be roses. We have to make difficult decisions, and not every decision will with everyone. And I think I've said before, I think this is about shifting to some extent our culture away from what has in the past been framed as this is a family to this is a professional workplace. Right. And that's not to lose an esprit de corps or a culture of positive workplace experience. A professional workplace can absolutely have those, but the standards of leadership behaviour and professionalism are what we need to redefine, perhaps.
But then that also touches upon the very fact that actually culture by its very nature is not static, and it's exactly that change that we're talking about is actually that professionalisation is quite a key component of that will enable us to be able to deliver our strategic aims. So I think that's quite a key part of the conversation.
After this phase either, we'll need to further develop our culture in collaboration through the group, and also our culture of collaboration with partners. Like historically, perhaps ambulance services have stood a little bit more alone, and we're making lots of progress in working more closely with partners, but still plenty to do there.
And Sarah will know certainly better than I. Just how important it is that the management team is seen to take appropriate action and take it quite robustly when that is necessary. And although that might be uncomfortable for the person who is the victim or the subject of that robust action, actually the views and attitudes of staff who will observe that, you will see that happening, cannot be underestimated. And if you want to change culture, then you've got to change that, well, nothing ever gets done around here kind of conversation, which is all too often the case. Because taking action is hard sometimes.
Yes, thank you. And I think the other point just to make, without restating the detail we went into in the People Committee, is that I think the report also recognised that there were a number of hotspots in certain areas, and I think you gave us some good reassurance. Thank you, Sarah, about the fact that areas that needed additional help are getting it, and overlaying that with the fact that we're doing this as a more generic approach, as the point's already been made, that these hotspots tend to move around organisations. You deal with one and then something else will happen, a set of circumstances. So I'm reassured by the governance that's being put in around that. And it feeds into the reports we're looking in here around triangulating all the data that we're getting around where those might be. So I take that as positive assurance. Thank you.
Good. Just it might be slightly controversial, but I suppose it's inherent in what you're saying. So I look at the strategic aim that I want people to enjoy. I don't actually have a problem with that, but I guess it's explaining what we mean by endure, and that kind of professionalism starts to put those boundaries around that. And the reality is that there's almost, you want the people to feel valued and therefore enjoy the outcomes of the organisation deliver through the efforts that they put within it. And it can be, and it's happened, you know, in quite a few organisations, where what seems like the right statement at the top can be interpreted through an organisation in a very different way. So I think inherent what you're saying is getting that professionalism, making those statements, being clear what we actually mean by that. I think that's really important.
Wise words about how things can be interpreted.
Oh, well, that's absolutely. And I was just enjoying it at work. If you were a misogynist and a bully, your enjoyment is rather different from somebody who's not.
Exactly.
But anyway, no, that's fantastic.
That's a really good point.
It is. Thank you. Okay, well, look, we're 1:05, so let's draw matters to a close, if I may. There were no questions from the public, I believe. No, so that's straightforward. As far as I know, there were no AOBs that were registered in advance, so that's good as well. So in that case, can I give apologies, particularly to Simon and 22 others who I know we cut short a little bit today, but you know, time is always against us. I hope it's been a good meeting for everybody. We'll take a 30-minute lunch break, which means we'll meet back here at 25 minutes to, so 1:35, and then we'll move into the private session, which should be fairly short, and there's only one particular item.